active regularly in the ISPN. The ISPN is the largest pediatric neurosurgical organization on the planet and has members from all over the globe. There are a variety of different services and resources. And one of the most important things is that we seek to foster membership amongst young people, not so young people, people across the spectrum, because we're all united in a single mission, which is to try and take the best care of children around the world that have problems that can be treated by neurosurgical techniques and principles. And so part of that is teaching those principles. And as the education committee, we coordinate a series of different entities to make that happen. There are courses, live courses, there are webinars, and there is the Clash of the Titans series. And we welcome all of that to your attention. This, of course, is the recurring webinar that's intended for young learners. It's entitled as medical students, but it's also for junior doctors. It's for house officers. It's for anybody that's at an early learning level in which we go over these basic principles. So please investigate the ISPN website. If you are so inclined, we would welcome your active participation and membership. It's a very robust organization, and we're very, very fortunate to have several of the stars, the really accomplished, thoughtful surgeons in the ISPN giving presentations today. So I'll turn this over to Noor Maria for introductions of our speakers. The program I've looked through, I think it's going to be outstanding. I'm really excited about this program. We've got some of the best and most experienced people. So fasten your seatbelts, friends. This is going to be a good ride. Noor?
Thank you so much, sir. Thank you so much, everyone, for joining us here. It's a matter of huge honor and pleasure to be a part of this amazing webinar series. I will take the pleasure of introducing Dr. Nabila Dalit. She's a neurosurgeon from Algeria. She's an assistant professor of neurosurgery at Algiers University. She holds a leadership position as the current vice president of the Algerian Society of Neurosurgery, and she's the first woman vice president of the Algerian Society of Neurological Surgery. She has written several papers in pediatric neurosurgery, and you might have listened to some of her lectures as well. Even during the pandemic, you might have been able to connect through virtual seminars. So she's very active in academics and education of neurosurgery. Today she's with us. We are honored to have her lecture on embryology and classification of Spina Bifida. Thank you so much, ma'am, for joining us today. The floor is yours now.
Thank you. I'm gonna share the screen if you allow, of course. Can you see my screen? Perfect, yes.
Yes, perfect.
Yes, ma'am. Yes,
Yeah.
perfect.
Thank you. So, dear colleagues, I would like to thank you for the kind invitation. I'm pleased to be here among prestigious neurosurgeons. First, I will talk about embryology of Spina Bifida and then on classification. Spina Bifida is mainly refers to defective fusion of spinal bony elements and is still and widely used to refer to spinal dysraphism in general. It belongs to neural 2 defect, which is a group of birth defects in the central nervous system resulting from failure of the morphogenetic process of neural tube closure. Human embryo presents as a disc with 2 cell layers, the bilaminar embryo, which contains the epiblast, the superficial layer, and hypoblast, the deep layer. The epiblast will give primitive streak and definitive embryo. Movements of cell toward and forward midline form a groove called primitive streak that will initiate gastrulation process. Development of CNS begins with the differentiation of 3 germinal layers during gastrulation and continues until birth. 2 types of neurolation were described, primary and secondary neurolation. The gastrulation is critical to early development of the embryo, occurs during day 14 to 15. It's a process induced by primitive streak and leads to conversion of bilaminar disc into trilaminar disc with 3 germinal layers, ectoderm, mesoderm, and endoderm. Primary neurolation is a process of transformation of a flat neural plate into a neural tube, occurring during the 3rd week of embryonic development. It's a complex phenomenon involving numerous cell processes and molecular control, often disrupted, resulting in neural tube defects. Neural induction by the notochord will lead to differentiation of primitive ectoderm into neuroectoderm and surface ectoderm. Then neuroectoderm will undergo thickening to form neural plates. Closure of neural tube involves complex morphogenetic movements. First, shaping of neural plate with apicobasal thickening, transverse narrowing, and lengthening. Then, bending of neural plate with a furrow in the midline of neural plate, and folding will elevate lateral edges, which will form neural folds and neural groove. Then fusion of neural folds that permits to transform the neural plate into a neural tube. After closure of neural tube, surface ectoderm will get disconnected from neural folds and fuse in the midline to produce continuous skin covering the underlying neural tube. The neural crest will get detached from neural folds and contribute to the formation of a peripheral nervous system. Lateral mesoderm will migrate dorsally between the ectoderm and the neural tube and form meninges, vertebral arches, and paraspinal muscles. The remnant of the notochord will give the nucleus pulposus. The neural tube will become CNS. It will give brain or spinal cord, and the cavity of the neural tube will become ventricles or central canal filled with CSF. Closure of neural tube begins at the 5th summit. The future craniocervical junction is extending in both cranial and caudal direction in a zip-like fashion. Before the fusion of the neural tube is complete, the cephalic and caudal ends communicate with amniotic cavities through cranial and caudal neuropores. The cranial neuropore closes first on day 25, and caudal neuropore closes on day 28. Once the neural tube has completely fused, the process of neurolation is complete. However, observations and experiments suggested that neurolation appears to involve several waves of closure among the cranio-caudal axis. Neural tube closes from the coordinated interaction of at least 4 waves of discontinuous neural tube closure. Early embryonic development is strongly controlled at the genetic level by regulatory genes coding for developmental proteins. Many of these proteins are expressed at many critical times during embryogenesis to orchestrate early tissue interaction, during gastrulation and neurulation, as well as the subsequent development of various organs. Several molecules are also involved in the molecular control of neurulation through signaling pathways. Some of this molecular control are PCP, or planar cell polarity, sonic hedgehog, and BMP, and the initiation and maintenance of neural tube closure depends on the complex interaction of mediators such as sonic hedgehog and its antagonists. Shaping of the neural plate is controlled by PCP signaling. Bending of neural folds is under the regulation of BMP and sonic hedgehog signaling, and there is an opening gradient of Wnt and sonic hedgehog in dorsal axis, ventral axis. Secondary neurulation occurs after closure of posterior neuropore according to a different morphological process. The caudal neural tube is formed without neural plate, and neurulation is done by mesenchymal condensation and cavitation. First, condensation of caudal tissue will give tail bud. Then cavitation in the central part of the condensation will give secondary neural tube. And finally, fusion of primary and secondary neural tubes. The following step is an apoptic process in which a combination of regression, degeneration, and further differentiation occur. The segment formed by secondary neurulation and retrogressive differentiation eventually becomes the tip of the canistel medullaris and filum terminale. Spina Bifida is a congenital malformation that results of failed closure or formation of the neural tube. It occurs during early stages of embryonic development. Open spinal dysraphism results from failure of primary neurulation sequence. It can be due to arrest of closure before fusion of the neural fold in the dorsal midline, failure to neural folds to elevate and fuse, failure of narrowing or lengthening process due to the inhibition of PCP signaling pathway and results in a short and wide body axis and given cranioschisis. Successful initiation of closure but subsequently cranial neurolation failure will give anencephaly, and successful initiation of closure but subsequently spinal neurolation failure will give open spina bifida of varying sizes and axial levels depending on the state at which the wave of SIPIN arrests. Myelomeningocele, which is an open spinal dysraphism, where the neurological disability is often considered as a two-hit process with a failed neural tube closure, followed by neurodegeneration in utero caused by prolonged contact of neural tissue with amniotic fluid. The open malformation leads to a leakage of CSF, lowering pressure in supra and infratentorial cranial compartment, leading to anatomical distortion and resulting in associated malformation, myelomeningocele, KRI2 malformation, hydrocephalus, cardiac lacuna, cerebral malformations, and others. In secondary neurolation, there is no closure component, so defects are not exposed to the external environment and covered by skin. Principal defect seems to be failure of the neural and mesodermal tissue to become distinctly specified and spatially separated. Distal spinal cord is often tethered to surrounding tissues. And failure of gastulation will impair the development of the notochord, resulting in a complex picture which includes spinal cord and other organs derived or induced by the notochord. Now let's move on to the classification of spina bifida. Several classifications were proposed considering clinical, radiological, and pathological aspects. Some classifications rely on embryologic anomalies. Tortori Donati proposed a recent classification of spinal dysraphism, including neuroradiological features with embryological correlations. Here's a clinical neuroradiological classification, which distinguishes open spinal dysraphism and closed spinal dysraphism. With the embryological classification is done according to the stage of the anomaly of the failure, and we distinguish anomalies of gastrulation, anomalies of primary neurolation, anomalies of secondary neurolation and retrogressive differentiation, and anomalies of unknown origin. Several types of spina bifida are categorized as open spinal dysraphism, and defect can be covered by thin membrane, but in most cases, neural tissue is exposed. It's the most severe type. And closed spinal dysraphism, where the defect is covered by skin, the ratio is about 9:1. In open spinal dysraphism, there is no radiological issue. 4 subtypes are identified: myelomeningocele, myelocele, hemimyelomeningocele, and amymyelocele. KRI2 malformation is seen in majority of open spinal dysraphism. Myelomeningocele is an open spinal dysraphism, the most frequent. It's due to failure of primary neurolation, where a portion of neural tube is frozen at a neural plate stage called the placode. It refers to bony defect with protrusion of meninges and spinal cord. The placode is elevated above the skin surface because of the expansion of the underlying subarachnoid space. And the myelocele or myeloschisis is characterized by the absence of the expansion of the underlying subarachnoid space. There is no distinction of embryological origin. It's the same entity in myelocele and myelomeningocele. It's considered as an emergency in both myelomeningocele and myelocele. Hemimyelocele and hemimyelomeningocele associate myelomeningocele or myelocele with split cord malformation. It combines failure gastulation and failure of primary neurolation in one hemichord, but in exceptional cases, both hemichords can be involved. Subcutaneous mass is a criterion for classifying closed spinal dysraphism into closed spinal dysraphism with a subcutaneous mass, mostly found in lumbosacral and cervical, and closed spinal dysraphism without subcutaneous mass, including simple dystrophic states and complex dystrophic states. In lipoma with dural defect, it's a closed spinal dysraphism with a subcutaneous mass localized in lumbosacral area, including lipomyeloschisis and lipomyelomeningocele, due to an anomaly of primary neurolation. Myelocystocele terminal is extremely rare. Meningocele is a herniation of CSF-filled sac through posterior spina bifida. containing aberrant nerve roots and also hypertrophic filum terminale, but no part of spinal cord. Its origin is unknown. Cervical myelocystocele is morphologically different from terminal myelocystocele, and its origin is not identified. Cervical myelomeningocele is different from lumbar myelomeningocele. It's less frequent. There is no tissue, neural tissue exposed, also called limited dorsal myelocystocele or myeloschisis. Simple dystrophic states are closed spinal dysraphism without subcutaneous mass, with its heterogeneous embryology because it includes defects of both primary and secondary neurolation, such as posterior spina bifida, intradural and intramedullary lipoma, filum terminale lipoma, tight filum terminale, the abnormally long spinal cord, and persistent terminal ventricle. Complex dystrophic states is a closed spinal dystrophism without a subcutaneous mass due to gastrulation failure that will impair the development of the notochord, resulting in complex picture, which includes spinal cord and other organs derived or induced by the notochord. The majority of anomalies are covered by skin without subcutaneous mass, except for the hemimyelocele and hemimyelomeningocele. Failures of notochordal development may essentially induce two subsets. Failure of midline notochordal integration, resulting in longitudinal splitting, and failures of notochordal formation, resulting in the absence of a given notochordal segment. In disorders of midline notochordal integration, we have dorsal enteric fistula, which is the most severe complex dystrophic state, neuroenteric cyst, dermal sinus, as you can see here in this picture, split cord malformations defined by incomplete duplication of two hemichord. Pang and al. Suggested to classify them in two types based on the dural tube and the nature of the median septum. Type 1 is destomatomelia with septum, like what we can see here in the picture, and type 2, destomatomelia without septum. Disorders of notochord formation include caudal regression syndrome and segmental spinal dysgenesis due to faulty gastrulation with a wide range of segmental vertebral malformation. Thank you for your attention, and special thanks for those ladies, late Professor Suad Barti, who was my inspiration in pediatric neurosurgery, and Professor Nelci Zanon, who gave me a lot of support. Thank you.
Thank you very much, Nabila, for these very informative lectures. And remember our close friend, we miss her, sure. It's important just to remind us about prevention. We need to know the embryology, to know the step by step and try to prevent these most common malformation on neurosurgery. Do you like to do some other words, Jeffrey, before move on? You are mute, dear.
No, we should let Summer have the floor.
Sure.
I'm happy to introduce Summer. Or Noor, would you like to introduce Summer, please?
I will do whatever you would like me to do. I'm happy in both ways. If you want to go ahead, then please do.
Sure, I know Summer. He's a good friend from a long time. He's a wonderful man and a wonderful neurosurgeon. He speaks well, he thinks well, and he always has the well-being of the child and the family first and foremost. One needs to speak to him for only a few moments to realize this. He's a pediatric and fetal neurosurgeon. He works in Orlando at the Arnold Palmer Hospital for Children. Under his leadership and direction, that center has really come to preeminence with regard to fetal neurosurgery, specifically intrauterine myelomeningocele closure. He's performed, at the time he submitted this, 90, but I bet it's closer to 100 now, fetal in utero closures, and he's going to take us through that here this morning. So, Summer, thank you. Welcome.
Thank you, Jeff. Thank you, Nelci. Thank you, Huda, for the kind introduction. It's a great honor to be with this wonderful, esteemed group of colleagues from around the globe. And thanks to the ISPN for putting together this wonderful series, educational series for medical students and trainees. Thank you, Jeff, for your friendship and for the kind introduction. It's great to give this talk after our friend, Dr. Nabila from Algeria. She gave an excellent talk on the embryology of Spina Bifida. My role over the next few minutes is to talk about the antenatal diagnosis and management. We heard an excellent lecture about the different types of Spina Bifida. This is a global disease. We're happy to see wonderful efforts from Jeff and colleagues about the role of folic acid worldwide and fortification and reduction in the rates of Spina Bifida. But what do we do when we have when we're faced with the antenatal diagnosis of an open neural tube defect? Our talk today would be focused on the open defects, myelomeningocele or myeloschisis. We all have to agree today that the standard of care as we speak today worldwide continues to be the postnatal repair. In North America, all of us, we try to get the repair achieved in the first 24 hours. In different places around the world, they do excellent work trying to get the treatment as soon as possible. But the goal is to get the defect closed as soon as possible. Here you can see from different babies from my own practice from postnatal repair, you'll see different outcomes, not only functional outcomes, but also hydrocephalus. We all should understand the pathophysiology related to the development of hydrocephalus and hindbrain herniation secondary to open neural tube defect. The best way to understand it for the students is the hindbrain herniation and the negative pressure at the base of the skull secondary to the fistula or to the leak at the site of the spina bifida. The higher the lesion in the thoracic or higher areas, the close to 100% cases of hydrocephalus requiring treatment. If we go down to the sacral level, the numbers can go down to 50% or more for hydrocephalus needing treatment of hydrocephalus. Most of us as neurosurgeons, we receive the phone call or the referral about an antenatal diagnosis around 18 weeks of pregnancy. The typical ultrasound will show a defect in the lumbosacral region or lumbar or sacral, depends on the level. Some of them are with a sac like myelomeningocele, and some of them are the flat type or the myeloschisis. Around the same time, between 15 and 18 weeks of pregnancy, you can actually start to see intracranial findings related to the spina bifida. You start to see the lemon sign. A sign has to do with the shape of the head inside the womb related to the development of the hydrocephalus. And you start to see the banana sign and the posterior fossa secondary to the smaller cisterna magna. And in some cases, you get a fetal MRI. Here you can see the ventricular megaly, the hindbrain herniation, and the defect. If we start talking about the early phase of antenatal treatment or prenatal fetal surgery to repair the defects in utero, it started around 1997 by mentors in the field from Chop and Vanderbilt, who started looking about reversing the pathophysiology by closing the defects early and looking for an impact if this will reverse the pathophysiology, reverse the hindbrain herniation, and eventually impact the development of shunt-dependent hydrocephalus. So they started with some series. They found a good percentage of hindbrain herniation reversal and less percentages of needing a shunt. Then the MOMS trial, the management of myelomeningocele study, went on for 7 years. It was a prospective randomized trial looking for prenatal repair between 19 and 26 weeks of pregnancy. The primary outcome of the trial was looking at the rates of shunting for hydrocephalus and mortality at the age of 12 months, as well as motor and cognitive outcomes at the age of 30 months. What is fetus surgery? Fetus surgery is basically operating both the mother and the fetus, keeping both safe while the fetus is connected to the mother through the umbilical cord for the surgeons, neurosurgeons to repair the defect if it was, regardless if it's a myeloschisis or myelomeningocele. Myelomeningocele then close the uterus and continue the pregnancy as long as possible to look for benefits. The results came out in March 2011. All of you can find the results published and you can download them for free from Google. When they looked at the prenatal compared to the postnatal groups, they found the rates of shunting dropped in half, from 82 down to 40%, and the hindbrain herniation improved significantly. The best news actually was not only about the shunted hydrocephalus reduction, but also the motor function improved significantly in babies who had fetus surgery, as well as the chances for independent ambulation also went up to 40% in the group that had fetus surgery. Obviously, all those good benefits for the baby resulted, as expected, in increased risks to the mother. Here we can see higher risk of maternal complications, most specifically premature rupture of the membranes and preterm labor, which eventually actually impacted the babies. We can say that almost 10 to 15% of pregnancies that undergo fetal surgery will deliver prematurely under 30 weeks of gestation. And this is a red flag from the MOMS trial, which continues to be a red flag for all of us who perform fetal surgery. Around half the mothers will go all the way until an elective C-section around 37 weeks of pregnancy. So the take-home message for the students and the trainees is that the MOMS trial showed that after fetal prenatal surgery to repair the spina bifida in utero, there is a reduction of the rates of shunting due to the reversal of the hindbrain herniation, and there's improved motor function, lower extremities, improved cognitive functions, but all those benefits are at the cost of increased maternal complications, most specifically preterm labor and potential prematurity. A follow-up recommendation came out from the American College of Obstetrics and Gynecology almost 5 years ago. This North American recommendation actually changed the way the care of spina bifida antenatally is practiced in North America. The recommendation came out from the ACOG saying that all women with pregnancies complicated by fetal open neural tube defects who establish certain criteria for any repair should be counseled in an undirective fashion about all treatment options, including fetus surgery. We were fortunate to publish our series for the first 60 cases. Most specifically, we looked at the ETV outcomes compared to shunting. Our series now between St. Louis and Orlando series and international cases we've been involved in around over 100 cases. We follow very strictly the inclusion and exclusion criteria. Per the MOMS trial, the inclusion criteria are myelomeningocele or myeloschisis between T1 and S1 levels. There has to be an evidence of Chiari type 2 malformation, which is hindbrain herniation. Gestation age has to be under 26 weeks, and there has to be a documented normal karyotyping via amniocentesis, although nowadays we do a microarray. The exclusion criteria is long. After the referral is received, we see the mothers quickly after screening over the phone. Maternal fetal medicine colleagues will do the evaluation, the ultrasound. We proceed with the amniocentesis to obtain a specimen of the amniotic fluid to send it for genetic testing, and the fetal MRI and consultations with different specialties. After the mother and the fetus are deemed candidates for the fetus surgery, we extend it to them not as a cure, not as a standard of care. We're very clear about all options, and we truly counsel the parents in an undirected fashion. If they elect to proceed with the fetus surgery under 26 weeks, this is truly a team effort in the operating room. We have to work as a team to keep both the mother and the baby safe. The mother comes in the morning, early in the morning. Epidural catheter is placed for post-operative pain control. She goes under general anesthesia. She's placed in lithotomy position. We do continuous ultrasound every 3 minutes throughout the surgery. We replace the amniotic fluid throughout the surgery. A low finish steel incision is made after general anesthesia. Then after going through the anatomical layers, the uterus is explanted. Specifically in cases when there's an anterior placenta, which is approximately 50% of the cases. In some cases, we have to use a retractor. Then we localize the lesion. We do the surgery together from A to Z. The maternal fetal medicine colleagues and the neurosurgeons in some programs. You can also include pediatric fetal surgeons, great collaboration with anesthesiologists as well as neonatologists being on standby. We localize the lesion and the placenta. Then we perform the hysterotomy with or without staplers. And then here you can see the back of the fetus is exposed. The amniotic membranes are stapled or sutured to the uterine wall. And this tube is bringing in amniotic fluid replacement. We use the microscope for the last 9 years in all cases. Here you can see this is myelomeningocele. This is the more difficult myeloschisis case. Again, after the lesion is exposed, we proceed with a multi-layered microsurgical reconstruction. The first layer we go for is retubularization or reneurulation of the plaque by approximating pia to pia, then truly try to achieve a watertight dural closure with or without grafting as well. And the last layer is the skin. Those are pictures from one of the first cases over 10 years ago. You can see here the plaque is covered by a watertight closure of the dura, but without neurulation. Nowadays, we neurulate all cases for the last 9 years. For the students in the on the webinar, here you can see if you look at the illustrations, we start with sharp microdissection surrounding the plaque. That is followed by reneurulation of the plaque using 8O or 10O proline to approximate pia to pia. You can see in the diagrams on the top how we go from flat to cylindrical shape plaque. This is after the plaque has been reneurulated. The next step is to achieve a watertight closure with or without myofascial flaps. It is very important to achieve watertight closure to achieve a true hindbrain herniation reversal. The last step is undermining circumferentially to achieve skin closure. In some cases, it is very easy to bring the skin together. Unfortunately, it's only half the cases. The other half, you have wider defects, and you have to either use mattress closure with or without inlay grafts. And for the very large defects, you have to use, especially for myeloschisis cases, when you have a wide lumbar fascia exposed circumferentially, you'll have to use onlay grafts. We use alloderm graft, which is cadaveric human dermis. We follow with ultrasounds on postoperative day 1 and 2. We start to see the babies actually go through a spinal shock. You start to see the leg movements working in the day 2, and by day 3, you start to see ankle and toe movements. We push for pregnancy to go as far as possible, obviously, but the goal is to achieve an elective cesarean section around 37 weeks. But the babies who deliver, who rupture their membranes earlier, we have to admit them to the hospital and monitor them for infection. Many of them actually make it as far as possible, but we try to push for the national average, which is 34 weeks of pregnancy. Even the cases when we use grafts, onlay or inlay, the way we suture them, we allow for epithelialization of the skin over the grafts, and many cases the grafts are exposed. We just manage them with wound care. And I can tell you that within the last 6 years, only one case went back for surgery after birth. All the others were managed 100% with simple wound care after birth if they need it. Here are some recent cases. And what I'm trying to show here, the importance of achieving watertight closure of the dura. This is actually the most important step of the fetus surgery. Within a few weeks after surgery, in 6 to 8 weeks, we get another MRI. Here you can see a nice CSF around the plaque because we did a good job with reneurulation. You can see here CSF around the craniocervical junction after the hindbrain herniation reversal. When we looked at our series, the first 60 cases, our average neurosurgical repair time was 43 minutes. When we look at the gestational age at birth was 34 weeks and 4 days. Our data now is around 35 weeks, which is much better than the mom's trial of 34 weeks and 1 day. Over half of our mothers would make it until an elective C-section. And we're fortunate with the outcomes regarding mortality. Mortality is around 3%, which is very similar to the mom's trial. And all the mortalities typically are due to babies born under 30 weeks of gestation. And we're monitoring very closely fetal surgery programs. We're monitoring for tethered cord outcomes. So now part of our protocol, we do fetal MRIs, postnatal MRIs around 6 months of age to monitor for tethering. When we compare the MOMS trial, prospective randomized trial, 3 centers, 7 years, 78 cases, we compare them to our initial series of 60 cases from 1 center over 6 years. When we compared the maternal, fetal, and neonatal outcomes, they were all very comparable. And there's obviously a learning curve, but for busy centers, the outcomes would be as good as the MOMS trial or better. When we looked specifically at our preterm labors, we found that the earlier we did the fetus surgery under 23 weeks of gestation, we had higher rates of preterm labor. So now most of our fetus surgeries are around 24, 25 weeks. I will not talk about the management of hydrocephalus since Professor Kulkarni would be giving an excellent talk on that, but we try now to look for candidates for ETV or ETV CPC. We're also part of the ST prospective randomized trial, randomizing babies with spina bifida and symptomatic hydrocephalus into ETV CPC or a shunt, but the jury is still out, and we look forward to have data from the ST trial over the next few years. But before we started the prospective randomized trial a few months ago, if the babies had a favorable anatomy, we try with ETV or ETV CPC, and our success rates, we published them, and our shunting rate right now is in the range 25%. It is very important early after birth to start looking at functional outcome and assessment and monitor those babies. Very important to monitor their milestones regarding their ambulation. Very important to monitor their function to see if there are any potential decline and concerns for tethering. But also as neurosurgeons, we need to continue pushing towards a less invasive surgery. Our hysterotomies are getting smaller and smaller. It's very important to monitor our outcomes. Some programs around the world are pushing for fetoscopic techniques, which are very promising. Still, the technique needs a lot of improvement so that we can measure outcomes similar to the MOMS trial, which was an open fetus surgery, which what we continue to monitor. But most importantly, the technique is not the most important thing. What we need to focus on are the outcomes, hydrocephalus outcomes, tethered cord outcomes, and long-term outcomes, and not to celebrate too early. If we have kids who are walking independently after fetus surgery, those are the kids we should monitor very closely to monitor for any tethering or decline in the future. We should monitor our outcomes openly and transparently. The NAFNIT, the North American Fetal Therapy Network, is an excellent platform for fetus surgery centers to enter their data for monitoring long-term. So in conclusion, antenatal diagnosis is key. First of all, the most important thing is prevention. But once we have a pregnancy with spina bifida, we look at outcomes, and we should be very honest with the parents about counseling them in a non-directive fashion. Fetal repair is very promising. It's gaining excitement and momentum worldwide. I personally believe in the next 10 years, probably we should start looking at many areas of spina bifida repair, that fetus surgery could be standard of care in some places after proving outcomes. Many international centers are doing the procedure, and we should track those outcomes. We as neurosurgeons cannot do this alone. We have to work as a team with colleagues from different specialties. And if we don't try, we will never know. It is important to monitor those outcomes long-term and to collaborate with centers worldwide. Thank you.
Summer, that was great. That was a tremendous summary of really the most updated ideas. We're monitoring the questions in the Q&A. Several of them pertain to very central elements, and I think Dr. Kulkarni's talk is going to usher some of those in. Could you just comment just a little bit more about the registry? Because I think the NAFNet registry is going to be particularly important as different techniques are pursued at different centers, right? Right now, there's sort of the fetoscopic and the open technique. The open technique is the only one we really do have class 1 data for, because the fetoscopic technique is different enough that we can't just take mom's data over to that. And it's going to be very important in moving forward to capture the very best available comparative data. For the postnatal care, just for the participants' aware knowledge, the CDC in North America maintains a registry called the NSBPR, National Spina Bifida Patient Registry. NAFNet is a more voluntary registry, and right now it's just North America. Tell us a little bit more about it. Is there a plan for incorporation of some of these well-designed non-North American centers? How is all this playing out? Could you develop that for us for a moment? And then we'll take the other questions after Dr. Kulkarni and Dr. Seal have a chance to talk.
Thank you, Jeff. I 100% agree. It is extremely essential for us to share data and to be part, all fetus surgery programs globally to be part of our registry. And I hope the ISPN actually will play a major part in this in the future at a global level. The NAFNet registry to track the outcomes of fetus surgery continues to evolve. I can tell you every year, we meet twice a year, all the NAFNet programs, part of this MMC registry, and we keep adding questions to the registry. And neurosurgeons over the last 3 years have been focused on truly looking at the impact of the neurosurgical technique on the outcomes. You know, the MOMS trial focused on the safety of the mother and focused on hydrocephalus and motor outcome and a little bit about cognitive outcome. But we're now monitoring them long term. The Tethered Cord outcomes are becoming a major issue worldwide after fetus surgery, and which technique is the best. All of us are improving our techniques to try to give the best outcomes possible. As we speak, the NAFNet is primarily North American centers. The questions that are being, or the endpoints being tracked in the registry, they are divided into 4 components: maternal, fetal, neonatal, and pediatric. And the fetal neonatal ones, the neurosurgeons are making continue to expand on the endpoints where we're collecting using grafts, using a microscope, using a fetoscope, using how many layers of closure, CSF leaks after birth, and so on. So at a North American level, the NAFNet, I believe, is now the best registry we have in our hands to track those outcomes. I would love to see a global level for fetus surgery outcome tracking. And I do believe that the ISPN should take the lead in that. You will find many obstetric societies, maternal fetal medicine societies worldwide focus on the maternal safety, but we, the ones in this group today talking, are the ones who are going to take care of those children until they're 18 or 21-year-old. So the registry continues to expand, but we need to look at a global stage for tracking fetus surgery outcomes. Thank you, Jeff.
Fabulous. We should move on with the talks.
Thank you
Thank
so
you.
much, sir. Sir,
Thank
I've
you.
got one question. Sir, I've got a little question
Noor?
as well. Yes, ma'am. Hello, can you hear me?
Yes,
Yes.
just one
Actually,
question, one comment before. We know for fetal surgery, we need to have antenatal diagnosis. Just to listen about Kaushik and Nabila, they are from other continents. How many % of the women, the pregnant women now, on this moment, have the precocious diagnosis on meningocele, just to have an idea, like ISPN policy?
It's almost 16% in my country. 1/6.
What
16%
have
a diagnosis, antenatal diagnosis.
60%?
1 in 6.
Kaushik? What?
1 in 6, ma'am.
Okay, thank
One
you.
out of 6, yeah.
1 out of 6, yeah.
Thank you.
But in Nigeria, we don't have any data about this. We have to do a lot of work and find statistics. But currently, we don't have any statistics about that.
Okay, thank you very much. We need to improve and going on. Thank you.
Thank you. Thank you for having me.
Thanks, Summer. Thanks, Jeffrey. Can you continue, Noor, to introduce Kaushik? Thanks for being with Kaushik and Sandeep some days ago in Kolkata, ISPN course.
Okay, thank you so much, ma'am. It's a big honor. I have a little question myself, sir. Sir, regarding the graft, sir, I have seen that there are several options such as the acellular dermis, sir. Sir, I've read that if you use this graft like an acellular dermis, there are chances that the patient will go on to develop dermoid cyst later. You can use the collagen matrix to separate it from the dura, but there are chances of the development of dermoid cyst. Sir, how do you consider the selection of graft and application of graft to avoid such complications?
Oh, thank you. So the graft I'm talking about is purely extradural. It is very important to achieve a maximal trimming of any extra skin tissue surrounding the placode before closing the placode, then before closing the dura. And this will lower the chances for inclusion cysts, dermoids or epidermoids. Any other skin grafts are superficial after dural closure.
Thank you so much, sir. Thank you so much, sir. And sir, what about if it is a segmental placode, sir? How do you think that we should proceed with the segmental placode fetal surgery?
It all depends on the appearance intraoperatively. If it is not safe to perform any suturing of the pia or reapproximation pia to pia, it is best to keep it untouched and to focus on closing the dura.
Thank you.
Just so that we can be respectful of everybody's time, we really need to move along so that we can allow each of our speakers time to give their talks. So Noor, could you introduce our next speaker?
Thank you so much, sir. I'm pleased to introduce Dr. Kaushik Sil, who is a senior neurosurgeon of international repute with excellent management skills. He has over 16 years of experience in treating complex brain and spine problems, including brain tumors, spinal disc prolapse, brain strokes, hematoma, etc. But he has got a special interest in childhood neurosurgical problems that include hydrocephalus and spinal birth defects. So he has a lot of contributions in several national and international conferences, and he has contributed and published several papers on pediatric neurosurgery. It's a pleasure for us today to have him with us to deliver a lecture on Spina Bifida, postnatal repair and care. Professor Kaushik Sil, welcome to our webinar. The floor is all yours now.
Thank you, Noor, for your kind introduction. And it's indeed an honor and privilege to be amongst you all. So, as you know, sorry, my slide is not moving. I'll just take a minute. So this is a picture from a Rembrandt's painting, which shows Dr. Nicholas Stulf. He is a Dr. Nicholas Stulf, who is giving anatomy lesions. Why I bring him here is because of this. Because at that time, it was Nicholas Stulf, showed us, he operated on a patient with a meningocele, and that unfortunate patient died. And he said that operating on a meningomyelocele would bring shame onto the surgeons. From there on, we have graduated. I apologize for being some problem in transferring slides. Can you all see my slides?
Yes. Yes.
Perfect.
So, and from there, you just heard about the fascinating aspects of fetal surgery. And so now my talk will be on some postnatal repair and care. What are the learning objectives for students and residents? Because for a meningomyelocele is the most common variety of Spina Bifida, and the simple varieties are what we call a senior residence case that you must learn how to do it alone. Problem is that what we just discussed about the asymmetrical demography, the exposure and training of residents to meningomyelocele are not uniform worldwide. We live in a country where there are a lot of cases. You may be living in a country where the exposure is poor. And it is this surgery that the timing of surgery and the completeness of surgery is paramount. And you cannot stop your buck just by completing your surgery. The parents and the child are all dependent on you for a long multidisciplinary follow-up for a long time. We've just heard about antenatal diagnosis, and many a times, some patients are directed, are presents with antenatal radiology, especially ultrasound, and if positive, then we can ask for a fetal MRI. This is a paper from my country, which in a small paper, small data, but you see, 75% of our people, of the mothers in this study, have no access to antenatal care, this blue part. And out of this, patients who are detected, patients and mothers who are detected with spinal dysraphism, only 16% were detected by antenatal screening ultrasound. You remember a very important word, that the typical obstetrical ultrasound transducers of 6 to 8 megahertz may not detect a neural tube abnormality. You will require a high frequency linear transducer to detect an early fetal abnormality in a child. If it is detected early, so what do you do? We do plan an elective cesarean section and arrange for transfer of baby to a pediatric neurosurgical care as soon as possible. You see this young gentleman roaming around, he was detected with antenatally with a Spina Bifida, and we arranged for a transfer for an elective delivery and transfer to our care, and he operated on the first day of birth, and now he is ready for school. But when the baby gets transferred to Spina Bifida under our care, the initial treatment is given in neonatal intensive care unit. There are some points. The baby must be maintained normothermic and euvolemic, along with the monitoring of vitals. It is very important to handle the infant with sterile non-latex gloves with sterile clothing and sheets, and keep the wound wet. We usually do, we keep the wound cover with a paraffin gauze on which we keep a lint, and occasionally make the lint wet, and on top of that, we wrap the baby and keep the baby under a radiant warmer. If the myelomeningocele are open and leaking, then we send first for culture, and upon receipt of the gram stain, if the gram stain is positive, we start broad spectrum antibiotic therapy. For the postnatal radiology and MRI of the whole myelomeningocele and area is a must, but along with that, you must insist for the screening of the whole spine of the brain. This is very important because 25% of these myelomeningoceles may be associated with other abnormalities like split cord or myelodysplasias, or even an ultrasound kidney is more important to detect abnormalities like horseshoe kidneys and other associated genetic abnormalities of the cloaca. In a postnatal presentation, what is important for a surgeon is to know what are the types of the placodes. The placodes may be open with a leaking CSF. The placode may be closed, or placode may be an open, now non-leaking, because initially the surgery was not done. It has now turned to a cicatrix. And for the surgical types, there may be two types of meningomyelocele. Either the placode is a flat and open type, what we call a myeloschisis, or it is a closed placode with a CSF sac, as we encounter in a meningocele or a meningomyelocele. There are some associated abnormalities which can modify your surgical approach. So hydrocephalus, Chiari malformation, tethered cord, syrinx, kyphoscoliosis are all affect your surgical planning. For example, you see the amount of scoliosis here, and this type of amount of kyphosis here, and this kyphosis may affect your wound closure in a small neonate. How to assess? We assess either with the small neonate for other malformations, for any syndromic appearance, for tone, posture, and extremity of the movements, for musculoskeletal abnormalities, obstructive sleep apnea, and indirect evidence of Chiari malformation. The SBNS Spina Bifida grading is one of the most important tools for standardizing the clinical presentation of a particular child And we all encourage you to go to this and follow it in your daily clinical practice. Remember, meningomyelocele may be associated with other systemic defects like increased homocysteine level, increased risk of atherogenesis, decreased hypothalamic pituitary axis function, so that may affect your surgical outcome or preparation. Now there's some ethical dilemmas. Will you treat every child with meningomyelocele? Take the example of this child. He was detected antenatally and presented with spastic paraparesis. He was offered surgery at birth. Then the surgery was refused by the parents. And then the child again came back after 3 months with this kind of ulcerated, huge swelling. Not every child you can treat. Not every child can get better with your treatment. So it is very important to counsel. Counsel not only the parents, but also counsel the other stakeholders so that everybody are on board about the future of the child. So how to plan your surgery? If it is a leaking meningomyelocele, we suggest to operate on the same day or at least within 48 hours of birth, so that to prevent colonization of the placode by skin commensals. If unstable, then the surgery can be deferred. And then if it is a large cystic swelling, like a meningocele or a meningomyelocele, we prefer a shunt unless the placode was infected. Here it needs to be addressed at approximately 1 year of age when the child begins to sit or to stand, and neurological problems and orthopedic problems keep on recurring. So the child and the parents needs to be counseled about future surgeries, say at least up to the age of 10 years, multiple future surgeries. So what are the operating techniques we follow? Proper padding is essential in the operating theater, maintaining the temperature, avoiding hypothermia, and measuring blood loss. We use a normal kitchen scale, only a normal kitchen scale to weigh the gauges during the surgery and take care and count the blood loss and replace it immediately for a small neonate. We may use neuromonitoring in older children, and what is very important to use magnification. It's very important to use loops, surgical loops, or my operating microscope, and not to do meningomyelocele just under open vision. It is important to plan the incision and the closure beforehand, before the surgery. We have seen the principles of surgery. The principle of surgery is to isolate the placode from the skin and the fascia, define the dural margins, reconstruct the pia, detether the cord, have a watertight dural closure, and a fascial and a skin apposition. For the preparation, in a case of cystic meningomyelocele, after the painting, we usually hold this with a sterile Alice forceps or an artery forceps, so that we can clean it properly, and use aspiration so as to decompress the swelling so that the visualization is better. Nowadays, we use this kind of drips that usually soaks away the water, so that the child is not hypothermic due to the water used during the surgery or from the water that leaks from the womb. Now, small things about the closure, how to approach. Initial incision is marked at the junction of the healthy skin, the placode, with a little bit of cranial extension. And it's important to separate the skin from the placode all round. This is carried all round the incision, and this incision is also depend on the fascia, so that the placode is separated both from the fascia and the muscle. The next step is to isolate the lamina, that is normal lamina, which is just above the level of the lesion, and to do a small laminotomy so as to expose the normal dura. And once the normal dura is exposed, then we have a plane to dissect. So once the dura is exposed all round, the part of the dura which is attached to the placode is separated. And the next step is a very important step, is to neurulate the placode so as to make it an open book, has to make it a closed book from an open book. We usually use an 8-0 or a 6-0 suture to close that close the placode. After the pile closure, it is very important to have a dural closure. A watertight dural closure is absolutely essential for having a normal post-operative, uneventful normal post-operative period. And in cases of older children, it is always advisable to search for the phylum actively and to cut it. In young children, it is also recommended, unless it is very far away from the operating wound, to actively search for the phylum and detether the cord. The next step is to closure. For the closure, a myofascial mobilization is required from both sides, a generous mobilization, followed by a skin closure. For the skin closure, you may need to extend the skin laterally, and then the skin apposition will become easy and it will be easier for you to close. However, in cases of large meningomyelocele, the repair may not be uniform. The repair has to be individualized and tailored for each of the patients. And in case of difficult surgeries, we can use a flap closure, either a rotation or an advancement flap. This particularly double VY plastic flap is my favorite part, where the closure becomes very perfect, though it involves a little bit of extra blood loss. However, with a little bit of caution and meticulous dissection, we can minimize the blood loss to achieve a closure. So there are some dilemmas we have discussed about antenatal and the postnatal surgery. Other thing is, so the other dilemma is to put in a shunt before or after the repair. If the placode is non-infected, cyst content is much more, you can go ahead and do the shunt before the surgery. Otherwise, if the placode is infected, it is better to postpone the shunt after the repair. Whether to use a transverse incision or a vertical incision. A vertical incision gives access to the upper unaffected dura easily. But mind you, all kinds of meningomyeloceles can be done with transverse incision. So little bit of experience after some cases, you can use a transverse incision in all cases. We have just discussed about the closure graft, autologous, artificial. Autologous is always preferable. However, in artificial graft, it makes no difference between the type of graft what is used. And about the pitfalls, you can have a CSF leak, you can have a wound dehiscence, you can have a shunt infection, or you can have a retethering in the long run. And the post-op care, we use prone position for nursing for 3 days, then side position for 2 days, along with antibiotics, transparent dressing. We maintain adequate nutrition. If at all we use a drain, we keep it for a prolonged period, and we remove the stitches after a long time. This is one of the innovative slings we keep the babies on with a small baby cot. Use a lint below the abdomen and hung it from a bar which is kept above the neonatal cot. So what are the outcomes? As you have heard, that independent ambulations achieve only in 50% cases, and people in long run do have persistent intellectual and neuro deficits. That's why the outcome, though in the short term is maybe excellent or good or fair, the early surgery is always indicated, because for the relief of the pain and also for the relief of the hydrocephalus and the Chiari malformation. So what is the take-home message? Take-home message is that you have to choose your case wisely and counsel extensively. For an open meningomyelocele, surgery has to be done within 48 hours of birth. If delayed presentation, then after 2 consecutive negative cultures. If it's a cystic meningomyelocele, the shunt has to be done beforehand. The dural closure, as was discussed, has to be done with a sufficient cord sac ratio so that the dura is expanded. In a case of complex meningomyeloceles, do not hesitate to take a plastic surgery help for complex closure. Keep the drain longer and avoid hypothermia and minimize blood loss. Lastly, the child has to be put under multidisciplinary care team for a prolonged time. Thank you all.
Thank you very much, Kaushik. Very important to stress that it's important not only the prenatal diagnosis, but also the counseling from families and the stakeholders, principally in the low and middle income country, because they don't have a lot of knowledge that is long life care these families needs. We may have some questions before move on, Jeffrey.
Yeah, so I think there are several questions in the question box. I think that we can take the ones mostly, I think, pertaining to these talks now. One of the questions that's there is pertains to the feasibility of in utero closure in countries of limited resources, and I think that's a big topic. But Summer, would you mind just commenting on kind of where that's at, because that I think is an important question that a lot of people are kind of milling about.
Thank you, Jeff. Excellent talk. The bottom line is what matters is the collaboration. The surgery itself can be done safely with limited resources. I watched the same surgery performed in 4 different continents, and I was in the operating room in each one of those ORs. And the surgery is very similar to any pediatric neurosurgery case. Sometimes you use microscopes, sometimes you don't. The replacement of the amniotic fluid can be done with simple methods. What matters is having a dedicated maternal fetal medicine team with expertise in caring for an open hysterotomy mother. It is highly recommended for any international team to visit another program to see the setup and to have a team with them on the first or second cases. I can tell you, I can count right now 22 international teams visited us in the last 5 years. And they come, they see, they set up, they go back to their country, they modify the protocol to make it fit for the local environment. We worked with many limited resource countries, and they're at the final steps of getting ready to perform their first case. This can get done. What's most important is not the neurosurgical side, actually. All of us can do this safely from technical standpoint. It's about the collaboration from the obstetric or maternal fetal medicine side and obstetric anesthesia. And it can get done, and it's happening in many places around the world.
Very good. So, Summer, 2 questions in the chat pertain to tethered cord following fetal release. We need to stay close to time, so I'm going to give you a tough task. Can you give us 60 seconds on your thoughts on tethered cord following fetal? And I realize how difficult that is, so I apologize and thank you.
With or without fetus surgery, all spina bifidas, or most of them, are radiographically tethered. What matters is the clinical deterioration. Most of us are not jumping to operate on inclusion cysts unless there's progressive syringomelia or decline in motor function. The bottom line is we need screening after fetus surgery. In the first 6 months of life or 12 months of life, it's important to get a baseline spina MRI as baseline, and to monitor motor function, not to operate based on a syringe, not to operate based on an MRI showing tethering, not to operate because there's an inclusion cyst. What matters is the clinical function or the motor function and monitoring it.
Fantastic.
Thank you very much.
Thank you.
We need to move on. Nor Maria, can you introduce our friend Abhaya Kulkarni, please?
And I'm really pleased to introduce Dr. Abhaya Kulkarni, who is a very renowned neurosurgeon. Every one of us who is in neurosurgery knows him for the ETV scoring system. So he's a pediatric neurosurgeon and professor of surgery at Hospital for Sick Children, Toronto. He's a senior scientist at the Sick Kid Research Institute and program director for the neurosurgery residency program at the University of Toronto. After a pediatric neurosurgery fellowship at Hôpital Necker Inform Maladies in Paris, he began his faculty appointment at Hospital for his Sick Children in 2003. So Dr. Kulkarni has published over 200 peer-reviewed manuscripts, and his research focuses on clinical trials, health outcomes, and quality of life in pediatric neurosurgery with special emphasis on hydrocephalus. So it is a matter of huge honor for us to have him here today at our at our course, and he will be sharing a lecture. He will be delivering a lecture on management of hydrocephalus in myelomeningocele. So welcome, Professor Kulkarni, and thanks for coming. And the floor is all yours now.
Great. Thank you very much for the kind introduction, and thank you for including me in this. It's great to see some of my friends from around the world. Great session so far, and I hope to continue with this talk. So this is going to be about management of hydrocephalus in myelomeningocele, and I will preface it by saying I'm going to aim this towards really some of the more junior trainees that are going to be listening. We can discuss more advanced topics later on if you want, but this is going to be very practical and dealing with the kind of stuff that you would need to know to do the basic management of hydrocephalus in myelomeningocele. And I'll begin very simply by defining what hydrocephalus is for those who are very new to this field. And it's actually not easy to give a straightforward, all-encompassing definition of it, but you can start with it, that it is the excessive accumulation of CSF in the ventricles of the brain under some pressure. And we've heard already about the incidence of this in myelomeningocele, and it roughly is on the order of 40 to 80%. There are a number of factors that go into it that Samer discussed, including whether prenatal surgery was done or not, plus other things associated with the lesion itself. But suffice to say, it is a common occurrence in children with myelomeningocele. And hydrocephalus in general is common for us in pediatric neurosurgery. And so here are some causes of acquired hydrocephalus that we see, often related to infection, hemorrhage, or tumor. But amongst those that are congenital or developmental in nature, myelomeningocele associated hydrocephalus is really one of the most common. It depends on where you're practicing and what the demographics of your practice are. But for almost everybody who practices pediatric neurosurgery, I think this is a rather large portion of the hydrocephalus population. And there's a question about, what is the cause of hydrocephalus in myelomeningocele? And that's not a straightforward question. I think there are multiple factors, and some of these are listed here. There are anatomical obstructions that you can see on MRI. There are probably issues with venous compliance, and there's probably some degree of scarring as well that you may or may not see necessarily on MRI. And I think that the relative contribution of each of these varies by child. Every child with myelomeningocele is really very unique and different. And I don't think you can look at an MRI and know exactly what the cause of hydrocephalus is. And I'll show you a case at the end that particularly highlights how little I at least understand about how some of these CSF dynamics work in hydrocephalus associated with myelomeningocele. So we know this happens fairly frequently. How do you know when it's happening? How does hydrocephalus present in myelomeningocele? And this is one of the challenges, right? For those who are experienced, it's pretty straightforward. But if you're new to this, you have to understand that the presentation of hydrocephalus in myelomeningocele is quite variable. It can vary temporally, so meaning it can happen at different points in the child's life. In some cases, it may be present right at birth. Or it may present over the first few days or weeks. And there are other cases where it actually is rather subtle and really only presents months later. I think it would be exceptional for it to present beyond that, but that's sort of the range of time that you can see it present after birth. And then in terms of so that's when it presents. How it presents is also quite variable. And what you'll hear referred to a lot in the management of hydrocephalus, both early on and especially later on in the child's life, is to always have in your mind a systematic top-down approach. And that applies as well to the presentation of hydrocephalus. So if you begin at the top, hydrocephalus can present in the very typical fashion that we see in children with raised intracranial pressure, where you get a progressive macrocephaly, splitting of the sutures, bulging of the fontanelle, sunsetting of the eyes, vomiting, irritability, maybe apneas or bradycardias. And then in older children, you may see papilledema. And that's a fairly typical picture of raised intracranial pressure associated with the ventriculomegaly. But that's not the only way that hydrocephalus can present in myelomeningocele. So if you move on down a bit, we've heard about the association of Chiari-2 malformation with hydrocephalus and, with myelomeningocele. And in some cases, the manifestation of symptomatic hydrocephalus is primarily a manifestation of Chiari-2 signs and symptoms. That may be breathing difficulties and apnea, swallowing and aspiration issues, or sometimes motor function loss in a quadriparetic ascending motor type fashion. And as you move further down, you can also develop syringomyelia, which is a accumulation of fluid within the spinal cord itself. And that can lead to, if that gets worse, it often is related to the hydrocephalus and can also present with things like quadriparesis and ascending motor loss, or if it extends high enough into a syringobulbia, difficulty breathing, apnea, swallowing and aspiration, brainstem types of symptoms. And early on, you can go right down to where the myelomeningocele closure site is. And if you've done a postnatal closure, then one of the manifestations of hydrocephalus might be leaking from that postnatal closure site. So these are all the ways that it can present. And again, top-down approach. So you have to always be thinking about the child fully, not just about the head. And because we know this happens fairly frequently, it's important to monitor the children carefully. And so that involves vigilant, close clinical monitoring with regular checks of their head circumference, feeling their fontanelle, they're getting a sense of where their sutures are, how splayed they are, what their eyes are looking like, and to keep good documentation of this. And what you're looking there for is clinical status with respect to signs of raised intracranial pressure, looking for evidence of breathing or aspiration problems, changes in their extremity strength. And then you always want to look at that myelomeningocele closure site to see that it's healing well and not leaking. And we supplement the clinical assessment and monitoring with imaging as well. And our protocol is to try to get an early baseline MRI. We don't always get it before surgery. We like to if possible, but as we've talked about these are postnatal closures that we're talking about. We do like to have the surgery done within 24, 48 hours. And most times we're able to get an MRI prior to that, but if we're not, I don't delay the closure for the sake of getting an MRI. We would at minimum get an ultrasound of the brain prior to postnatal closure. But we do try to get an MRI within the first few days. And certainly a child that was born after a prenatal closure, we as well try to get an MRI early after birth. And then after that, we often rely on ultrasound, which is a really good and useful way to follow these children. If they haven't already developed hydrocephalus during the time of their inpatient stay, then we follow them fairly closely in the outpatient clinic, roughly every 2 to 4 weeks, depending on our specific level of concern with the child, using brain ultrasound. And really a big point of contention, I think, and a point that I really take a moment of pause is determining when to treat hydrocephalus in these children. Because what you'll find is many of these children will have large ventricles. Sometimes they're born with it. Sometimes they develop it early on in life. They may be enlarging a bit. But I don't think that in itself is the threshold to initiate treatment for hydrocephalus. And I'll point out that this used to be the threshold. Even I think before I started practice, I took over Robin Humphrey's practice, who was a very senior, esteemed neurosurgeon. And I saw some of the patients that were now teenagers that he had shunted, 15, 18 years before I started practice. And the practice then it was basically accepted that a child with myelomeningocele was going to develop hydrocephalus. And as soon as their ventricles started to expand, they were shunted. They didn't wait for clinical signs or symptoms, and that was it. And we don't do that now, I think. Certainly we don't in Toronto, and I think most practitioners don't. I acknowledge that there are certain local factors in terms of access to resources and that probably go into that type of a decision, but our threshold is clearly higher than that now. And so, yes, we look for evidence of moderate to severe ventriculomegaly, and then at least one of these following. And what I've put here are basic criteria that we've articulated within our hydrocephalus clinical research network. And they've generally served us well. You can always find a case that probably needs treatment but doesn't quite meet these criteria. There'll always be these one-off cases, but this is a general good outline, I think, of when you should consider treatment. So having ventriculomegaly plus a large head with some evidence of raised pressure in the form of a bulging fontanelle or splayed sutures, up gaze palsy, a CSF leak, papilledema, vomiting irritability with no other attributable cause, bradycardias or apneas with no other attributable cause, or obvious Chiari-2 or syringomyelia symptoms in a child with myelomeningocele. And once you've crossed that threshold, you've decided the child needs treatment, the next dilemma is what to treat with. And there are basically, I will say at the outset, the standard option is ventriculoperitoneal shunt. Having said that, in some cases and at some centers, another option might be endoscopic third ventriculostomy with or without choroid plexus cauterization. And they're two very different treatments. VP shunt, very common operation. It is the standard pediatric neurosurgical operation. It involves a soft rubber silastic tubing that's hollow that goes into the brain, attached to a valve mechanism that regulates CSF flow through the long distal rubber tubing that goes into the peritoneum. Okay, very common operation, very straightforward to do technically, and works well to control macrocephaly and other symptoms and signs of hydrocephalus. But the other option that we have been exploring more recently is the use of endoscopic third ventriculostomy, where this involves placing an endoscopic camera through the frontal lobe into the lateral ventricles and then into the third ventricle to make a hole here in the bottom of the third ventricle to allow sort of an internal diversion of CSF. Now, this is not feasible in all patients, I should say, right? So, and particularly with myelomeningocele, you can see a very unusual constellation of anatomy in that base of brain. And so you have to look very carefully at the MRI to determine if the child will be eligible for it or not, or if there is some unusual anatomical feature that might make an ETV really not feasible or safe. This is what a standard ETV looks like. This is the endoscope in the right lateral ventricle with the choroid plexus and the enlarged foramen of Monroe here. And then this is the floor, the thinned out floor of the third ventricle through which you can see the top of the basilar artery and infundibular recess. And here you're making the hole here and expanding the hole, and that allows this hole here allows for the diversion to the prepontine cistern and subarachnoid spaces. But we know that the success rate of ETV alone in babies in general, but in myelomeningocele in particular, is not terribly high. And so more recently, for those of us who have been doing endoscopic treatment of hydrocephalus in myelomeningocele, we tend to supplement the ETV with cauterization of the choroid plexus. And we typically do this through a flexible endoscope, which is the view that I'm showing you here. And this is in the left lateral ventricle. You can see the pink-red choroid plexus here that we're just sequentially cauterizing with a monopolar cautery as we're moving along here. And you just move along the choroid plexus of the lateral ventricle on the ipsilateral side, and you move that over to the contralateral side through a septum pellucidotomy. And what you're aiming for is here again, we're seeing the blanched choroid plexus. Now it's not pink anymore. We've made a septum pellucidotomy. We're going through to the other side. We've already completed it on the other side, but just to show you what you're looking for is that the blanched white choroid plexus now instead of the pink red choroid plexus that I showed you before. So that's what, and you do that for both lateral ventricles. So that's what choroid plexus cauterization is. And I won't go into the literature on this. There suffices to say that there is literature that supports this as a reasonable treatment and alternative to ventriculoperitoneal shunting, but it is highly debatable as to whether it is beneficial and in what ways. It is a riskier operation. It is a more technically challenging operation. So it's not straightforward that just because you can do ETV CPC that you should. So I will reiterate that I would say that ventriculoperitoneal shunt is the international standard for treatment of hydrocephalus in myelomeningocele, but in certain circumstances, ETV CPC can be offered. Personally, I think it should, if it's going to be offered, it should be done in some form of a research context so that we can learn from it. It doesn't have to be in the form of a randomized trial, but for us, that is what we're doing. So Samer and Jeff are participating in, their centers are participating in this study, which is a North American-wide randomized trial comparing ventriculoperitoneal shunt to endoscopic third ventriculostomy with CPC. This is not just for myelomeningocele patients, but I think a large portion of this patient population will be myelomeningocele patients. And hopefully over time, we'll get some results from this. And the important thing about this study is we're going to look at cognitive outcome as our primary outcome, which I think is crucial, as Samer and Kaushik had mentioned. We really want to know how these children are doing in the long term, not just the survival curves of failure rate and such. And these procedures have complications, right? So whether it's shunt or ETV CPC, you can get infection and meningitis, you can get wound complications and CSF leaks, you can develop seizures postoperatively, shunts can overdrain, shunts can block, ETVs can block. And particularly that last point about blockage or failure of these devices over time is a crucial one. And I'll take you back to what I started out with, which is that top-down approach. So a child who's been shunted or has an ETV, if these fail at some point later in their life, it can present in very unusual and different ways in patients with myelomeningocele. And I refer you back to that top-down approach where we went from, yes, it could present as classic signs of raised intracranial pressure, headaches, vomiting, lethargy, et cetera. It could present with Chiari type exacerbations. It could present with syrinx and loss of function in the extremities as well. So anytime a child with myelomeningocele has any sort of a neurological change, always go back to this top-down approach, because often it's inadequately treated hydrocephalus that's the cause that they're losing their arm function or something like that. And that's not intuitive, right? But with experience, you realize it's obvious, and you start there. And just as a very dramatic case of this, just to highlight, I show this to our graduating residents so they never forget. This was a child, a 10-year-old with myelomeningocele who was shunted at birth, had never had any previous revisions of her shunt, and then had presented on New Year's Eve with sort of a very mild quadriparesis and mild difficulty walking. She was ambulatory, quite high functioning. And we got an MRI. Unfortunately, she had been lost to follow-up, so we never had a baseline MRI for her. So we didn't know what her spine looked like, but she had this unusual configuration in that she didn't have any headaches. There was no papilledema, and her ventricle size was stable. So we were working her up, and literally within 12 hours, as December 31st went to January 1st, she became quadriplegic and ventilator dependent. And so this is what her MR looked like. You can see that whatever this cyst was, whatever you want to call it, is larger. There's more signal change around the cord. So she's clearly getting brainstem, upper cervical spine deterioration. And, immediately you think, well, this must be some sort of local phenomenon, some cyst, something. She's got I didn't show you here, she's got a complete aqueductal occlusion. There's, as far as we can tell, no anatomical communication between her ventricles up here where her shunt is and all of what's happening here. But you go back to that top-down approach, and in fact, this was a shunt block. And we fixed her shunt, and this is what she looked like, and she'd fully recovered. So this is a very dramatic case. They're not all that common to see this such a dramatic thing, but I present this so you never forget that top-down approach for patients like this. And I'll stop there. Thank you.
Ab, would you comment on imaging with regard to ventricular size and shunt failure in hydrocephalus and myelomeningocele?
Yeah, so I think that last case highlights the point that you can't. So specifically with regards to shunt failure, as you work up a child for shunt failure or ETV failure, one of the things you look for is if there's a change in ventricle size, but that does not always happen. And particularly in myelomeningocele, you'll see more of those cases where you don't get that. And so you have to be very, you have to have a high level of suspicion whenever a child with myelomeningocele presents with almost anything, and think about the shunt really as the first target of your intervention.
I don't think that can be overemphasized. Every center that deals with a lot of spina bifida hears sad tales of children that are treated at centers that don't deal with as much spina bifida that are refused shunt exploration based on no imaging change. And it almost always precipitates a period of often irreversible decline, which is tragic. Shunt first in myelomeningocele is a dictum you hear around the world and over time with centers of great experience. Nelci?
Yes, just some quick question for 1 second answer. Abaya, we use your ATV success score. Did you use this score to decide if you revise the shunt or if you do ATV on myelomeningocele patients, VP shunt malfunction?
That's a great question. So I think, yes, when they're older, I certainly do contemplate the use of ETV at the time of shunt failure. I dictate it more on the MRI, and I would like to see them at a certain age before I do that, but I look very closely at the MRI, trying to get very detailed, thin fiesta type images in the sagittal plane. to determine the feasibility of it. And if it is feasible, and particularly in a child who's had a difficult course with shunt problems, then I do make a point of offering it. I've not had a tremendous amount of success with that in the older children that I've tried this on. I've actually had probably more success in doing ETV CPC in babies with myelomeningocele than trying to salvage a repeated shunt failure patient of an older age.
Thank you very much. We need to move on. And I encourage the speakers to answer the questions on the chat, please, just to advance a little bit. Nora Maria, please, can you introduce our friend, Eileen?
So, thank you so much. It's a matter of huge honor and pleasure for me to introduce Dr. Elim Ukal, who is Assistant Professor of Neurosurgery at the University of Arkansas for Medical Sciences and a Pediatric Neurosurgeon in the Division of Pediatric Neurosurgery at the Arkansas Children's Hospital. She is involved in various clinical research projects, quality improvement initiatives in neurosurgery, and has published articles in peer-reviewed medical journals. Dr. Ukal is a member of several international and national medical organizations. He is an active member of the International Society of Pediatric Neurosurgeons, and that is the ISPN, and also the American Association of Neurological Surgeons, WFNS, CNS, the Congress of Neurological Surgeons, and the Society for Research into Hydrocephalus and Spina Bifida. He's very active in all the conferences and in neurosurgical education, and she's a really inspirational women neurosurgeon for all of us, especially the junior women neurosurgeons like me, including me, and it was a pleasure to have her in Pakistan a few years ago. Although unfortunately I couldn't meet her because I was not in my hometown, I was away, but it was a matter of huge pleasure to know that she was in my hometown and in my homeland, basically, and to teach my peers and my colleagues were really inspired by her. So it's a matter of huge honor to welcome her here today. She will be sharing her lecture on long-term follow-up of patients with Spina Bifida. So welcome, madam. It's a matter of huge honor to welcome you here today. The floor is all yours now.
Thank you so much. I am so happy to be here with you, and I have been following Noor's career for a while, and I know she's gonna do great things as the next generation of neurosurgeons, hoping that she's gonna continue her career as a pediatric neurosurgeon. Thank you so much for your kind words, Noor. And I really appreciate my mentors, Nelci and Jeff, for their invitation. It's a great honor, though it'll be a very difficult task to follow all our experienced colleagues after the fact that they have given their own, case reports and reviews and about Spina Bifida. But I'll try. I'm happy that they have already presented some of the follow-ups for specific cases and specific conditions in Spina Bifida, and my aim with this topic would be just to summarize some of the long-term follow-ups and what we look at from a neurosurgical perspective first, and maybe secondly from a more holistic approach, like Jeff always mentions, from another perspective. I have no disclosures, but I'm happy to be a part of the Global Alliance for Prevention of Spina Bifida via folic acid. That was founded by our mentor, Jeff Blount, and his colleagues, and I'm happy to be a part of this as well. So when we're talking about the Spina Bifida, we're talking about the myelomeningocele, like Spina Bifida aperta, and it remains to be the most common congenital central nervous defect worldwide, as you have seen from the presentations. It's been a topic of interest for the World Health Organization, global outreach efforts, as well as all of us in neurosurgery and our professional organizations. My learning objectives for this talk was certainly I aimed it to the more younger generation and audience, like trainees in our audience, but was to give a perspective of long-term care for patients with Spina Bifida as much as I can, and to highlight some of the associated problems faced beyond infancy until adulthood. Certainly, I want to discuss some of the topics, maybe more controversial topics, maybe more philosophical topics of how to improve our outcomes and how do we achieve better outcomes in in the sense to emphasize that we need multidisciplinary care for these patients, starting from prenatal care till adulthood. But a brief history to know, as Professor Sill has given, is it was initially the 17th century where the term spina bifida used. And Dr. Nicholas Tulp was a son of a Dutch weaver who first used the term. Since then, we came a long way. We do not know what the exact estimated prevalence of spina bifida in the world is, but we think that it's anywhere between 2,000 up to 3,000, maybe two live births in 1,000. But those studies mostly come from higher income countries or more developed countries where the registries are present. But this is the numbers that we can get from the WHO and the professional organizations. But we do know that our patients with spina bifida have lifelong problems, not only neurosurgical problems that we've been emphasizing throughout, but a bunch of other issues, including orthopedic problems, urological problems, problems related to their sexual function, psychology, social issues. So it's many. As we said, I want to give you a little bit of facts about the lifelong problems. We know that the lifetime risk of death is 10 times higher for spina bifida patients when compared to the general population, and that's not good. Before the 1960s, and that's roughly before the invention of complicated or sophisticated, I should say, shunts, the mortality rate was up to 90%, and mostly due to meningitis and hydrocephalus. Of course, urological, orthopedic, sexual, nutritional, and cognitive and psychological problems come later, what we actually, recognize as our patients survive. And we have talked about shunts and shunt-related problems, as well as associated other issues, such as carry-2 malformation and syringomyelia, as well as tethered cord, but the problems go beyond neurosurgery. We know that severe disability may occur up to 33 of these patients or our babies, no matter what. But there are good outcomes as well. Since the advent of new technologies, new techniques, and not in only neurosurgery, but other branches, we know that despite selective treatment or euthanasia or, stillbirths or death, about 75 to 85% of the babies, the children that we treat at birth or treated at birth can reach their adulthood. This is mainly data from the developed countries, but I tend to believe, and I want to believe, that this would be the case in lower middle income countries as well. The 1-year survival rate among infants with myelomeningocele is up to 96%. And 85% of these babies survive to attend school. 80% of them can maintain social bladder continence if they have the resources. And 90% will have acceptable bowel function if they have the resources. 75% of them will be able to walk. And IQ levels, which is a big topic in neurosurgery and other circumstances, is about above 80 when the patients are not shunted. So there are good outcomes to it as well. And as we mentioned, the survival increased since the 1980s. Dr. Halter and his friends and his colleagues started inventing shunts and more complex ways of treating hydrocephalus. The new techniques of ETV, CPC, ETV, in lieu of the in utero closure, starting from the MOMS trial in 2011, has significantly increased the rates of better outcomes, and certainly much more better outcomes in terms of motor, sensory, urological, orthopedic functions, in addition to only neurosurgical functions. And as Dr. Kulkarni has mentioned, as we followed, ETV, CPC, ETV or guidelines, or used a strict criteria for shunting these babies, we improved our outcomes in terms of treating hydrocephalus, treating carry-2 malformation-related problems, and possibly syringomyelia. Carry-2 malformation in these patients is seen more than 90% of the postnatal closures, However, control of hydrocephalus has taken care of KRE2 symptoms mainly, and it's very rare that we operate on these patients for the KRE2 malformations anymore in this era. But hydrocephalus continues to be a problem in spina bifida patients in adulthood. We shouldn't, get into this, waters that it doesn't cause any issues, but it does. We have to remember that hydrocephalus is a lifelong problem, as we mentioned in the beginning. Even though the number of literature in adult hydrocephalus with spina bifida is low and improvements in overall outcomes have resulted prolonged survival, they still have problems related to the hydrocephalus. Dr. Domina has published a paper with his colleagues, which was published recently, looking at a pediatric cohort as well as an adult cohort of patients through registries. They looked at about 13,000 patients, more than 13,000 patients with spina bifida in their registry, but their findings were actually similar to pediatric population. They found that about 49.6% of these patients, adult patients, will still require surgeries or treatment for hydrocephalus. About 33% of them will require tethered cord procedures. About 32% of them will still require KRE decompressions. So going back to what we wanted to emphasize, it is a lifelong problem and it doesn't change. No, we mentioned tethered cord briefly in other talks, but I want to emphasize that tethered cord is one thing that we follow in the long term of our babies. And technically, all of our babies with spina bifida are radiographically tethered. The problem is the symptoms. If they're clinically symptomatic, clinically tethered or not, is that is actually like determined as you follow these patients. We follow these patients closely. Even though they're all radiographically tethered, only 1/3 of them will require surgery, and maybe another 15% of them will require a retethering, a redo surgery for tethering cord. And it usually is during growth spurts, which also hence the need to emphasize that they need to be followed not only, at their childhood, but above adult, beyond puberty towards adolescence. And now with an earlier, with the invent of in utero closures, there are studies that show that Samir has mentioned as well as Jeff that tethered cord is becoming more common in a younger age. But let's go back to our outcome facts. We said that outcomes are good, but going back to adults, we don't know much about spina bifida as our patients grow. The adult spina bifida is a topic of interest to our organizations, and I know Jeff has extensively published on this. But as our population of spina bifida patient ages, we discover that they have other issues. And those issues go beyond, as I was trying to emphasize, beyond neurosurgery. Many of those adult patients, even like they pass puberty after the age of 18, die from renal failure or cardiac problems. A few of them die because of shunt-related problems, because we know these problems and we can follow them much closer. I think everyone is more educated on following shunt-related problems or KRE-related issues. But in another clinical-based sample, again, renal failure, cardiac problems, sepsis were the leading cause of that, not hydrocephalus, not the KRE directly. Certainly, as our population of spina bifida patient ages, we come to see that they have hypertension, they have hyperlipidemia, they have cancers like the rest of the population. They have other issues. Something that we have not touched is sexual dysfunctions and infertility, including urological outcomes. Living conditions, and as they age, they need work opportunities and social and financial support, which we do not investigate or research in extent. Well, how did we improve outcomes is another question that I want to discuss with our trainees listening. So I believe that we achieved improved outcomes of our patients by having multidisciplinary teams, by using a more holistic approach rather than looking into one part of our patients. Because as they age, we've learned that they have significant problems. Mainly, those problems they come from the abnormal central nervous system, which affect the other organs and the function of the other organs. But as they age, we've learned that it's very important to follow them neurologically from a gastroenterology point, from orthopedics point. Actually, this is a patient of ours who required surgery for orthopedic deformities. And, just comes to us now, our patients and adolescents have questions about their sexuality, their, future families, their fertility. So, obstetric and gynecology becomes a problem. Physical medicine and rehabilitation is something that I cannot emphasize, as strong as maybe I should, but it's very important, and I believe creates a lot of miracles and has improved our outcomes for these patients greatly. Social works, financial counselors, neurology, diagnostic imaging and testing, technicians and our radiologists are all should all be a part of a multidisciplinary team. And that is how we achieved improved outcomes, especially in higher resource settings. And I have to mention that, we followed strict guidelines from the neurosurgical societies. These guidelines has been published in 2018 and has been followed, in centers in the United States, and I know in Europe and some other global. But these guidelines mainly refer to the patients with postnatal closure. The following strict guidelines and doing this standard of care for every patient around the globe, I think will also improve the outcomes of our patients. The neurosurgical guidelines were divided by age, including from prenatal, till puberty, infancy, and up to adolescence, as well as adulthood. But I want to mention to you that how important it is to take care of spina bifida, not in the sense that we're, for improving outcomes of our patients, but we also think about how it affects the healthcare in general, especially the cost of spina bifida, not only here in the United States, but around the world. As our population of spina bifida patient ages, we know that that might cause a lot more issues to the healthcare costs every place around the world. So I have the numbers from the United States, certainly, that we look into cost of our spina bifida patient to the healthcare system. And it is yearly, median hospital cost for an infant with spina bifida is about $20,000 a year, which is increasing every year. So, what about the low resource settings? We talk about long-term follow-up. We talked about diagnostic testing, technology, neurological improvements, orthopedic improvements, a multidisciplinary team, and a cost of spina bifida is high. But what do we do in a low resource settings to follow these patients and to better the outcomes of these patients as well? Dr. Park and Dr. Worf has published the guidelines, very comprehensive policy recommendations for lower middle income settings. And some of the colleagues here in the audience are actually advisors for this policy recommendations. But here are my own take on how to improve outcomes in the low resource settings, putting aside the higher income countries. I think collaboration in between disciplines is very important. And education of our team members, not only healthcare providers, but the public, the communities, is very important. Taking into socioeconomic factors and supplementing those socioeconomic factors in terms of at the government level, the policy level, is very, very important. That needs to come from sometimes bottom to top, from communities' requests to the top, but also top to the bottom, from governments down to the communities where the need is present. course, we have to improve our healthcare workforce in order to establish multidisciplinary teams so that we can follow our patients in the long term with the highest standards. Nonetheless, whatever we do, it's very important to have a multidisciplinary teams where we can and involve other healthcare providers in, helping our patients with spina bifida, improving outcomes, taking care of our patients with spina bifida. Certainly, prenatal care, prenatal education is important so that the families have a better understanding of what they're gonna see, what they're gonna expect, and in the life of their child. Transition of care, which we have not, touched on this talk very very depth, is very important as our patient population ages. But mainly, I think we need to focus on prevention. And as I conclude, I want to, just challenge our audience to find themselves in this map. The green are the places where the prevention with folic acid fortification, mandatory folic acid of fortification is being done, are the countries in green. The countries that are in yellow with moderate prevention or no prevention of spina bifida. So I challenge our audience to find their country in this map and work on prevention if they're not green on this map. And I think that would be the future that we need to focus, since I don't think we're going to be able to solve the problem of spina bifida or other very complicated, comprehensive neurosurgical pathologies, just I guess in a political way that just just by talking about them. Certainly there has to be a lot of resources, but prevention might be much easier in terms of how we can achieve our goals. So as I conclude, I'm happy to take your questions.
Thank you very much, Eileen. Fantastic lecture. And you finished with prevention. Maybe Jeffrey can give some words about what is going on prevention.
Well, I think we really appreciate the call out, and particularly the call to action, because this is an area where we in neurosurgery, I think, have a unique opportunity. Just in brief, we have a front row seat to the challenges and the problems and the suffering of the children and the family. We enjoy a position in society where people care about what we think, and we can leverage that to let what we know become more widely known to people that make important public health decisions. And that's what the GAPSP effort is about. We still have more talks to go today, so I don't want to spend very much time on it, but very much appreciate the call out. GAPSP welcomes any and all from around the globe to participate. I can be reached through this webinar, or Ilham or Rick Boop, our president of ISPN, all very active in this initiative. We would welcome anyone. We have a Twitter feed. We have other ways to connect with us. Please, if it's something that interests you, there is great work to be done wherever you are on the planet. I'm going to pivot. I think Dominic's next. Yep, right, Nelci?
Yes, he's right. Thanks for coming. Nor Maria, can you introduce our friend Dominic, please?
Yes, please. It will be a matter of huge pleasure for me. I'm really honored to introduce Dr. Dominic Thompson, who is a consultant in pediatric neurosurgery, and he's an honorary senior lecturer at the Institute of Child Health. He's a regular faculty member on international training courses in pediatric neurosurgery. He has written numerous chapters for textbooks on pediatric neurosurgery and neurology. Mr. Thompson has a long-standing interest in developmental abnormalities of the spinal cord, in particular spinal dysraphism. He has previously spent part of his training in Paris, Chicago, and California in order to pursue his interest and observe other models for multidisciplinary management of these conditions. He runs a regular multidisciplinary clinic for the management of spinal dysraphism. This clinic incorporates the nursing consultants for biolomeningocele, neurology, and physiotherapy. It's a matter of huge honor for us to invite him today at our module, and we are really pleased to have him. So welcome, sir. And we are really glad to have you here and to invite you to deliver your wonderful lecture on the surgery for lumbosacral lipomas. So the floor is yours now.
Thank you very much indeed, Noor, and indeed Nelci, Jeff, and the rest of my friends on the panel. And I think it's really been a great afternoon. So really well done for organising that. We're going to sort of switch tack a little bit now, because obviously up until now we've been speaking mainly about the myelomeningocele, and obviously that lies within the group of the open neural tube defects. At the beginning of the afternoon, you heard how the spectrum of spinal dysraphism can be looked at in a sort of developmental way. And in fact, it's only myelomeningocele where we really have a good handle on the underlying embryology. For all these other pathologies at the bottom there, it's very much conjecture. More recently, there have been new disorders put in, the so-called junctional neurolation defects that you may come across in your reading. But really, for the purposes of my talk, we're going to move towards this group of conditions, the lumbosacral lipomas. And these are very distinct from open neural tube defects. Yeah, these are not associated with hydrocephalus. They're not associated with Chiari for the most part. I think it's important to understand exactly what pathology we're talking about. And I think in your reading for the junior consultants and other neurosurgeons on the line here, we must remember we're not talking here about fatty phylums. Yeah, so we can forget that group because they're developmentally different. Their prognosis tends to be excellent, and the surgery is generally fairly straightforward. What I'd like to do, though, is perhaps again, when you read about, look through the book chapters and the published literature, one can sometimes get the idea that things are more clear-cut than in actual fact they are. And I think there's a few misconceptions that I'd just like to have a look at before I talk specifically about the surgery. And I think the first is that lipomas are a well-defined entity. Yeah, this is simply not true. In fact, we use this rather outdated now classification of dorsal, caudal, and transitional lipoma. Moderators has now put in a new classification, which is very sort of embryologically based. But of course, more recently, we've seen different descriptions. Professor Pang's talked about the chaotic lipoma. There are lipomas with extraspinal extension, as you can see here. And there's even conditions that are often confused with lipoma, terminal myelocystocele. Why is this important? This is important because prognostically, it's likely that each of these is actually quite significantly different. And lipoma type, I think, does make a difference. This is the results of, on the left there, you see a study that we did some years ago looking at asymptomatic lipomas and what happened to them in their natural history. And you can see that there were significant differences between the different types. When you get the nasty transitional type lipomas that we're looking at here, these are really quite a significant surgical challenge. By contrast, last year we published this series looking at a group of lipomas where you could actually see the conus was there, but obviously fat put onto the back of it. Yeah, and these had a much, much better prognosis. In fact, of all the ones that we followed, there were 26 in this group, only 4 clinically deteriorated during the time of observation. I think another misconception is, we always consider that deterioration in lipoma patients is due to tethering of the spinal cord. And again, in your reading of the textbooks, you'll have come across the concepts that are started by Shoki Yamada in the 1980s. And he undertook a very elegant set of experiments where he put traction on the bottom of the spinal cord in cats and looked at the changes in blood supply and electrophysiology at the bottom end of the spinal cord. And he showed that the more you pulled, the more damage that you created. But these were cats. Yeah, they were normal spinal cords for cats. They weren't malformed. This was a model of acute tension, not chronic tension. And so it's not necessarily applicable to immediately move this, particularly to the lipomas. On the right there, you see an operative picture of a thickened or fatty filum. And I said we weren't going to talk about these, but actually I put it here because this probably does show a more typical, if you like, tethering type phenomenon. And when we do the operation, we divide and it moves apart quite satisfactorily. But if we look at a picture like this, a complex lipoma, is the problems that this child has got, are these really related to just simply traction on the bottom of the spinal cord? Is this a problem of deformation, or is this a much more bigger malformative problem of the terminal spinal cord? And in this paper from a few years ago on the right there, this was just a pathological analysis of lipomas removed at surgery. And you can see there's a whole spectrum of different tissues within the lipomas, suggesting that this is much more a hamartomatous type malformation of the terminal spinal cord, not just simply a normal spinal cord with some fat stuck onto the back of it. And another thing that one will commonly come across is that patients who have surgery do better. And again, this is simply not true. Abkul Khani, who you heard from earlier, and in fact ourselves have both done natural history studies on lipomas, and certainly some children with lipoma do deteriorate, but not all. And in fact, up to half in these two studies did not deteriorate over time, and in fact had fairly similar Kaplan-Meier survival curves. But of course, it's not over whether you operate or not, it's what sort of operation you do. And Dakling Pang, who's been one of the foremost workers in this field, in his study from 2011, showed that actually partial, if you like, which was what the sort of operation that people have traditionally done for lipomas, had actually quite a lot worse outcome than those who underwent his more radical new technique of near total resection of the lipoma. And indeed, many of you know, I've been working with Dakling Pang over recent years, and we've just published this series of almost 100 lipoma cases. And you'll see here that the radical resection does seem to be significantly better than partial. But in fact, look, conservative management is probably better than even partial. So often you're better doing nothing, than doing a very subtotal removal. But remember, this curve is progression-free survival. It means the likelihood of having another operation. It doesn't mean that these patients are remaining completely asymptomatic. So, as I say, the talk was really titled The Surgical Management, so I'm just going to do a few words on the surgical management. Initially, one has to think, what strategy for management are you going to take? Many people have the view that lipomas will likely deteriorate over time and they should have surgery. Many have however, taken a more questionable approach and have only selected those who have symptoms to go for surgery, whereas those who don't appear to have syndrome, they're selected for observation and only operated in the event of a deterioration. So the operation that is probably the most, I think, sort of maybe controversial at the moment, but is getting a lot of traction, is that described by Dakling Pang, and the one that we have been using more recently. And the principles of that operation are as follows. The first thing is you really need a wide exposure, removal of the pedicles almost to the side so that you can really see around the front of the spinal cord. Monitoring is an essential part if you're going to be doing a radical resection of a lumbosacral lipoma, because you really need to have a handle on what potential damage you're doing to the nerve roots. And the selection of monitoring techniques when it comes to spinal cord untethering, is a little different that one might use for spinal cord tumors or spinal deformity. We don't use SSEPs, we don't use D waves, but use a lot of MEP, mapping of nerve roots to find out functionally where you are, and also the bulbocavernosus reflex, which gives you an idea of local reflex arcs. The muscles we choose to monitor are chosen so that we measure the entire lumbosacral outflow, so that during the operation you're getting a reasonably good idea of the innervation and how it's been maintained to all the muscles of the legs. And here you see the setup and the various muscles, the standard placement of the cranial stimulating electrodes. This is we use a stimulating electrode to actually touch the nerve roots to do the mapping part of the procedure. And here, for example, you'll see what the electrophysiology sees. We touch a nerve root. Here you can see that it's the left abductor hallucis there that's got the biggest response. There's a little bit of response on the anus, so that's telling us we're probably at about the level of S2. We also use the bulbocavernosus reflex as a means of trying to give an idea of the integrity of the conus region. This is a little bit more experimental, but nonetheless helps keep a guide during the process of the surgery. The aim then is to try and resect the lipoma along this plane between the fat and the underlying spinal cord, and hopefully to reconstruct it into something that looks something a bit more like a normal conus, and then to complete with an expansion duroplasty. So just to show you some of the steps of the surgery, and in the interest of time, I'll be moving this along as we go. So you can see to the right is the proximal exposure opening. And again, as with all dysraphisms, for the young surgeons on here, always expose over normal tissue first. Yeah, always go from normal to abnormal. And you can see now that the opening of the dura is being extended around the side of the lipoma, because the lipoma, it's almost like a hernia coming through a defect in the dura. And at this stage, one's simply delineating the margins of that hernia. If I move along, you can see now this is looking down the left side. You can see this is dura that's being exposed. These roots, these are the roots at the bottom now of the chorda equina. And again, at this point, you can see this is where one's doing the stimulation, working out what the functionality of these various nerve roots. And obviously, we're going to be maintaining those, the integrity of those during the course of the operation. The actual resection of the lipoma begins at the top end. Yeah, this is the easiest place to find the interface between the fat and the underlying spinal cord. There are often a number of small vessels that are coming through that, and you can see it's important to use very short stamps of the microbipolar there, and the irrigation is keeping it cool so you're not doing any damage to the placode. And then gradually one's working from proximal to distal, lifting the lipoma away from, and you can probably see on the video that whiter plane underneath, which is obviously more normal spinal cord. And gradually that resection of the lipoma is continued more and more distally. As you get more distally, the interface can become a little more difficult to see. But nonetheless, one gradually takes the resection of the lipoma all the way down. And of course, throughout this point, you're going to be regularly measuring the MEPs. You're going to be testing with stimulation if you think you're near nerve roots. And eventually the lipoma is resected off the back of the spinal cord. The edges are then approximated in the midline. Initially, just you can see with these little liga clips, and then you can see we're just starting to place some of the monofilament sutures there, 8O nylon to do the neurolation, and then those liga clips are removed, leaving a hopefully reasonably reconstructed cord. Now you want to leave some space now for that spinal cord to be in. So here is the placement of the dural graft that then we try and do a watertight placement around to prevent further leakage. Here's another examples of some of these reconstructed spinal cords. And this, the expansion duroplasty is quite an important part of the procedure. As I say, if I just move along to that, you can see these very close stitches being placed in. And just towards the end, what we'll do is inflate with saline. You can see we're just putting in a catheter there to inflate the reconstructed fecal sac. Blow it up with saline to check that you've not got any obvious CSF leaks around the margins, and you can see there it's how it inflates with the saline. And once you've done that, then one's just got to finish off the suturing and close up in a usual multi-layered fashion. And this is what one's aiming for, to try and convert the lipoma on the left to as minimal amount of lipoma within the largest fecal sac that you can achieve. Here's another example, again a more chaotic type. and here's what it looks like afterwards. But it's on the axial. Here's the preoperative on the left, and on the postoperative, you can see what we've tried to achieve is improving this ratio between the new spinal cord, and the overall fecal sac that you've created with the duroplasty, the so-called cord sac ratio, because this seems to be very predictive of the likelihood of late deterioration. So I guess to finish, this was really just a summary of the principles underlying the surgery. Pang's paper explains this in a lot more detail, but this is a big subject to cover in the time. I guess the question that is important, and again, particularly for young neurosurgeons to think about, should though all cases with lipoma have surgery? And I think here there is a definite question to be answered. I told you that some people, again, we went from that idea of all children having surgery to being more selective. I think now that even this is wrong, because it's very difficult to know, particularly at a small baby, whether they are truly asymptomatic, because they have an evolving bladder, and it's very difficult to know at what point the bladder is normal or abnormal. And I think going forward, for me, what we need to be looking for is how to differentiate the low-risk lipoma that you can simply watch from the high-risk lipoma that really should have this a much more radical procedure. So I think in summary, remember the lipomas, they're not a single simple entity. They are very heterogeneous with different processes. I think tethering, is only one aspect of deterioration. You must not forget that some of these, there's an intrinsic severe malformation. I don't think that necessarily all lipomas should have surgery, but I think if you are going to operate, I do believe that a more radical approach guided by functional monitoring is likely to give you a better progression-free survival compared with just doing a partial simple resection without dealing with the residual lipoma on the back of the spinal cord. But as I say, by what criteria should we decide who has surgery? That's the question for your next generation and the rest of you young surgeons listening in on this. So thanks very much for your time. I'm sorry, Jeff, if I've moved slightly over time, but thanks for everybody's attention.
No, that was not only comprehensive, but I want to bring to the younger surgeons' attention the new data in that talk that was absolutely critical. To just take a moment to put this in a historic context, many of us, young, old, in between, have looked at Dr. Pang's work and have wanted to emulate it, but have struggled to do so. Recognize Dr. Pang dedicated a significant portion of his life to dedicating to optimizing and perfecting this technique. Others have tried it, and many children have been hurt along the way trying to pursue radical resection without the dedication to excellence in neuromonitoring, really this lifelong and really tremendous dedication. When Dr. Pang does these resections, this is not an hour-and-a-half or 2-hour operation. This is a long, day-long, meticulous operation. And so many people have tried to do this and have been unable. Many people have said, I'd love to be able to, I would believe the radical resection information if and when someone other than Pang can present us the data that shows that. And that's what you all just saw. Dominic Thompson has taken Dr. Pang's technique and has done a cohort of radical resections, and you saw the curve go by. Radical in London equals radical Pang. Now, that's not to say that the young surgeons on this call should immediately jump into radical resections. Dominic, would you speak to that point, please?
100%, Jeff. And as I say, obviously time constrained a little bit. So thanks very much for your comments. But I think there's one very important thing to say. You look at those curves and you think, oh, brilliant. How great am I? Yeah. Remember, those curves are looking at the likelihood of needing a second operation. Yeah. And when I was doing partial resections, I was getting so frustrated. I'd do these operations, then a year or two later, the kids are no better. You're back in doing more surgery. Yeah. But what those curves do not say is that those children are all neurologically intact and doing great. In my series, almost 30% of the children, are on clean intermittent catheterization. That is a big number. But then we've got that's a selected cohort. So I'm selecting, if you like, slightly high risk cases. But have I hurt children doing this surgery? Most definitely, I think I have. And I think you're absolutely right, Jeff. This is not an operation. You read the paper and you give it a go. I still think that this is very difficult surgery. And I think that's exactly why, because it's high risk, why we need to be selective. And we really need to look at the cases where this is justified to do a big operation. And that's where Dackling and I disagree a bit, because he would say surgery for everyone. I think actually we really need to hone in on who is going to benefit most.
And then just one more comment, if I may, just to put it in context, and I think we should throw it open to the floor and others. But this, for the young surgeons, this is where we're really up against it, because the traditional teaching has been, if you see 100 children that have a lipoma, lipomyelomeningocele at age 2, precious few of them have demonstrable neurological problems at that point in time. If you just take that 100 patients and don't touch them, the traditional teaching, and I'll circle back to this in a moment, but the traditional teaching is that 75–80% of them will show significant pain, girdle distribution, aching, serious pain, progressive dysfunctional lower extremities, problems with the sphincters, a whole cavalcade of misery, right? So untouched, a vast majority of them have problems. And so the question has always been, do you take a given risk for whatever the surgical risk is at your center in one day, compared against this 75–80% risk of the natural history of the untreated condition over time? And this is where Dominic's work and Abaya's work and the French group's work and others have raised important questions about that. Is 80% really the number? Can we really lump them all together, or can we as a group begin to recognize differences between them and stratify or categorize these into different types of lipoma? And it still remains a challenge. There are classification systems, but it remains a challenge. So that's kind of where we've been at, and I think these are the really important questions going forward. With that, let's throw it open to whomever. Dominic, do you have any points to add to that?
Not at all. No, very happy to hear what other people have, their experience or questions. That would be great.
Thanks for advisors. I think you put the very clearly tips for surgery to help to decision. If you indicate surgery, start for the normal tissue, start for above, and going back, and 2 more tips you give to us. First, open widely the canal, the maximum possible. You have all in your hands. And after doing your job, try to close hermetically the dura mater with a graft. Without dural graft, it's already decided that we will not have the wide canal that we are looking for to avoiding retethering. And you are very happy to give us this advice. And just to remember the audience, questions about lipoma start in 1995 in one Argentinian ISPN meeting, because the question there, it was, do we know the natural history of the lipoma? It was the French group with Alain Pierre-Kahn. And since then, Alain Pierre-Kahn and after Michel Zerat start just observational studies. And they shows that with time, some deterioration happen, and will be the key in the future, try to know who is the high risk group. And now we have numbers that the partial resection is worse than no surgery in some cases. And I have this discomfort, and when the people coming back with a partial surgery we did 10 or 15 years ago. And I think we are changing our mind for the numbers, for Professor Pang's work. And now we are moving on to total resection when we indicate. Sure, remember monitoring. Without monitoring, it's a very risky surgery if the patient doesn't have symptoms. It's open.
Ma'am, I think there is also, I really request any of you to highlight this point, that is the cord sac ratio that might help us to determine the incidence of retethering. Ma'am, so how do you see this? Would anyone like to kindly highlight the point of cord sac ratio and other things that might help us to determine the incidence of retethering?
I mean, I think I would go back to the point that I think Samir was making earlier, and I think others have made. Just like in myelomeningocele, the diagnosis of retethering is ultimately clinical. I mean, as I say, I would never reoperate on a lipoma patient solely based on a bad cord sac ratio. Yeah, the thing about the cord sac ratio is it's giving you the best prognostic information of the child. If you've got a cord sac ratio of 30% or less, it's very unlikely you're going to reoperate. And in fact, in that series of nearly 100 patients now, I've reoperated. I think in that series, it's literally 2 cases. It's very unusual, but you're taking an initial much bigger risk with the patient in order to achieve that. So, you know, it's a question of where you put your risks. Do you put them early in surgery or late in natural history?
Dominic, there's a couple of questions in the QA about how to follow a patient with spinal lipoma in the case you decide not to operate. Can I call on you? And I don't know if Abaya is still with us. He had to turn his video off. He may have had to attend to something, but I'd be very curious what each of your thoughts are about appropriate ways to follow a patient with a spinal lipoma that you don't operate on.
Yeah, sure. Absolutely, very happy. So really from the simple, there are a number of, many of them, they come to us as neonates or in the first few months of life, yeah. If they on neurological examination appear to be normal, yeah, for all of them, yeah, we get a urological assessment, yeah. They get assessed by, and we do that on a 6-monthly basis until the child is continent, yeah. After that, it's reduced to annual, and then often it extends wider than that as the kids get to 7, 8, or 9. But it's that first 2 to 3 years up until continence. That's your real worry time. By the time a kid is walking and they're continent, yeah, you've got a much easier child to follow. But yeah, that's my bottom line. And of course, if the urology drops off, the neurology drops off, or they start getting pain, that's the kicker to move towards thinking about surgery.
That's exactly like to the word our follow-up protocol as well. 6 monthly till they're continent, and then annual thereafter with urological follow-up as well with those.
Sorry, I just wanted to make it because I think a very important thing that I think always in this discussion gets omitted, and that's people, you know, and it's what neurosurgeons really mean by urological assessments. Yeah, we all think that we send this kid off to the urologist and they put him in a black box called urodynamics and they come back with an answer, neurogenic or normal. Yeah, and it is simply not that simple. You know, you speak to urologists, yeah, and assessing bladder function in the pre-continent child can be exceedingly difficult. And I'm sure, presumably you find the same thing with your urologist. You know, should you do, you know, formal urodynamics? You know, does manometry of the bladder actually help you? In the developing bladder, you often do get a degree of detrusor, sphincter dyssynergia. That's part of learning continence, and you have to be very careful not to assume that those automatically mean abnormalities. So I think we do have to have a dialogue, and I think part of going forward is for us to liaise a lot more with the urologists, have a much better means of assessing and following the bladder.
Yeah, that's really important. Yeah. Sorry,
Dominic.
No, I just want to.
Yeah.
Thank you so much, Jeff. So that's what I was with the long-term follow-up talk. I was trying to shy away from giving timelines for these patients when they have to be followed, when the first MRI needs to be done, how we follow them every 6 months, years, and all that stuff, because I want to emphasize, and as you all know more than me and better than me, is that not every setting has their same resources. And I think that is a big challenge in following, especially patients with spina bifida or patients with lipoma that have no symptoms of retethering or hydrocephalus or whatever. So it is difficult to classify all of them in one pocket and then, use these guidelines of following very closely at 6 months, 3 months, your dynamic studies and all that stuff. And apply that to every setting all around the globe. So from more experience, my colleagues like Dominic and Nabila, Nelci, you, Samir, just, is there any practical ways that we can actually advise our trainees to follow these patients? What would be the most practical way to do it with the resources that they have or they might have?
Sure, and it's a very good question and a very practical one for many people. And so, for example, one thing I think you can do to help with resource is not do regular MRI scans. Yeah, the MRI scan in an asymptomatic kid will stay the same. They hardly ever change. And if the kid is clinically well, don't repeat the MRI scan, would be my view. I definitely do a post-op scan, but if the kid is staying fine, you don't need to do that. And I don't think you need to do very complicated urodynamics either. I mean, we do something called a bladder function assessment. You need to know how well the bladder fills, when they've had a wee, how well it empties. That's a simple thing that an ultrasound can tell you. It's not perfect urodynamics, but if you're in a limited resource situation, that's going to give you some really helpful information.
I think that we do have here in the residual urine volume that we can proceed with. I'm from Pakistan, so we do have the same things of limited resources. The only thing that we have that we can easily ask for is a residual urinary volume in ultrasound scans. And so we do not even have this intraoperative monitoring. So what would you advise in the absence of any intraoperative monitoring? What would you advise to safely respect the lipoma maximally?
So, I mean, I must admit, my view would be, if you don't have monitoring, you're really going to be very much going down the conservative line of management much more commonly. Because I think certainly to do the radical, if you're really going to be going down to the white plane, fiddling around with nerve roots, I think you owe it to your patient to be able to monitor that properly with neurophysiology. I think if you don't have the neurophysiology, you're going to be you're going to have to leave some fat, because you're not going to have the confidence to take that off. But as I say, those very limited partial resections, as I say, you're better off probably doing nothing than just doing what we call a peek and shriek, getting in there, taking a bit of lipoma, closing it all up and hope you've done something good.
Amazing, sir. Thank you so much, sir. It's a pleasure to listen to all these things. And there's another question in my mind that we say that if in those patients, in the MMC patient, the myelomeningocele patients, in which we have not introduced the VP shunt preoperatively, and we operate them, and after that they develop a CSF leak, and there is a frank egress of the CSF. There's some people usually prefer that instead of introducing a VP shunt at that point when the CSF is leaking through the wound, we should better go for an EVD, because they believe that even a low pressure VP shunt will not be able to prevent that leak, and why the EVD will be a better option. So what's your experience regarding this, that in a patient with a MMC repair who has developed a CSF leak, a frank egress, do you really think that EVD is a better option than the VP shunt at that time?
Sorry, is that I mean, I can give, I suppose Samer, I'll probably give you the lead. I mean, I must admit, from my point of view, I always take the view, if you get a CSF leak, you have to assume that it might be a surgical problem, that actually you just haven't done the closure well enough. Don't just immediately go straight to putting a shunt in. It might be a reflection of underlying hydrocephalus, but not necessarily. I must admit, I think if there is a pseudomeningocele there that's a bit tricky, if you're going to, I must admit, I would rarely put on EVD. I would normally go straight to shunt, and that normally drops the pressure and I think gets control of the situation. So I must admit, I'm not a big one for EVD in myelomeningocele.
Thank you so much, sir.
Summer, you were going to make a comment earlier.
Yes, Dominic, my friend, thank you so much for the excellent talk. And thank you for putting together this wonderful data from London, extremely important for all of us. My question to you is there enough data globally about the volumes of centers of doing spinal lipomas annually compared to outcomes with partial or partial radical resections? In other words, now we have a lot of trainees listening to us today. Should we treat a spinal lipoma like craniopharyngiomas or complex brain aneurysms where we have enough data to justify sending those complex cases to tertiary care centers to be operated upon by surgeons with experienced hands? What are your thoughts about this?
Yeah, I mean, it's a good question, Sam, and always a very controversial one. I'm sure it's controversial in the States and many other parts of it, and it's definitely also controversial even within the National Health Service in which I work. But I genuinely do believe that there are certain conditions that are sufficiently rare and sufficiently resource intensive that do benefit from being in small centers. And in fact, now, and it's because of that, I no longer do brain tumors, because I actually have a group of people who do all of them, and they do them a lot better than I used to do them, and so, they give me all their spinal cases, I give them all my brain tumor, and it works perfectly. I think it's only with volume that we can start to make an impact on knowing more about this. We've just finished, actually, and we'll be publishing later in the year, hopefully, a systematic review on the available literature on lipomas. And I'm afraid, myself included, you can say very little from the published literature, because the groups of patients are so variable, the interventions are so variable, the time at which they're done is variable, and the outcome measures are variable. So you end up with a whole mass of stuff that's very, very difficult to interpret. And I think you have to start being very specific and only looking at very specific groups with very specific outcomes. And you just simply can't do that without volume patients. So at the risk of maintaining the controversy, I'm afraid I agree with you. It's been achieved in fetal surgery, so there's no reason why it couldn't be extended.
It raises the issue of registries, doesn't it? Right? I mean, how would you propose, we've talked about being able to sort out and distinguish. Your closing slide was low risk lipomas versus high risk lipomas. For all of its wonder, at this point in time, MR doesn't seem to be a granular enough or precise enough metric to be able to sort those out. Urodynamics are a very subjective study. You sit in with the urologist and you realize it's like reading a good novel, right? Everybody has a favorable experience, but what one person takes from the novel is quite different from what another does. So, there's some objectivity in urodynamics, but that's pretty subjective as well. Have you thought, Dominic, or do you have any thoughts about how we can move forward with beginning to improve our characterization? Is this going to be a functional thing? Is this going to be, what are your thoughts on how we're going to improve and recognize the low risk from the high risk?
Sure, and I think that's where for me that's where the money is. It's trying to find out what are the really good prognostic criteria. I don't think we should ignore. I was a bit sort of dismissive of the Chapman classification. I think it's done its role for 2030, but we need to move beyond that. I do think there are going to be some techniques in MR that will help us. Because I say even that simple study we did where you have a morphologically intact conus, they tend to do pretty well. It's all of those ones with where they just massive spinal cord disappearing into fat. They're the real nightmare ones. And I think there's a question then as to whether are they even a surgical target? Can you actually change that? But we've looked at things like CSF lipidomics even. I wonder whether there might be something even electrophysiological in the future that you can do as a preoperative investigation. But I think, all these things I think are ripe for some blue sky thinking, because I think without that, we just in 10 years time, we're still going to be in the same position. The conservatives are going to be arguing with the pangs, and we won't be taking it any further.
So I was just pausing a moment to look at the questions in the Q&A. I think that's exactly right. I mean, this is the direction in the questions for the future. We still have a couple of minutes left. I don't by any means mean to monopolize. I want others to ask questions. Dominic, while others are gathering their questions, or Summer, Ilham, anyone, what are your thoughts on lipomas in adults?
Did you say in adults?
Yeah, in adults.
I mean, in my experience, when I stopped doing adult neurosurgery, but I used to receive a lot of referrals with what's called adult tethered spinal cord. I believe it's overdiagnosed. There are some rare cases where you can pick clinical radiographic tethering in adults. Typically, at least in my experience, when they stop growing, as long as you manage their tethering successfully for the right indication at the right time during childhood and they stop growing, almost always is not indicated to do anything after into the adulthood. But I welcome Dominic and other colleagues to give answers. Our practice is very similar to what Professor Thompson described regarding maximal safe resection, which equals safe radical resection, or doing nothing is better than doing subtotal resection. This is what we do right now in other busy program here.
Yeah, Jeff, I mean, I must admit, I'm fortunate enough not to have a big adult spinal practice myself, because I know they can be very difficult. I know, speaking to Taghlit, he used to do quite a few adults as well to comfort. And I think he acknowledges that actually outcomes do tend to be suboptimal for their difficult surgeries. Recovery rates are high, and outcomes, particularly urological outcomes, don't tend to be great.
Nelci, you do some adults, don't you?
You ask me, Jeffrey?
Yes, yeah. Do you do do you take care of adults?
I don't take care right now, but I was on call, and a 45 years old man, he was waiting for a surgery more than 5 years. The adult surgeons doesn't like to touch him because it's children pathology. And the pediatric neurosurgeons tell him that he was too adult to be taken care. And he was just losing the capacity to work, to walk, and to go the steps. And we decide to operate him. We doesn't give back the function that he was already left. But we stop the progression. He was losing motor function and vesical function, and maybe more than 4 years now, he's still in the same level. Yes. But it was not more difficult than it was in children. But he wasn't diagnosed until the symptoms. It was a small lipoma. It is not a huge one. And it was the only adult case that I operate. But now I re-operate my own patients, 18 years, 20 years old, 25, that I operate when he was young for retethering.
Hey, Kaushik, I'm very curious what you and Professor Chatterjee think about, because you cover both adults and children. About 10 years ago, I started following some adults in an adult clinic, and it really seemed that the people with lipomas had a tremendous burden of pain in adulthood. And I've wondered many times whether we could help these people with a more proactive approach to adult lipoma. Do you have any experience to share in that regard?
Yeah, we have a series of around
is 7 to 8 adult these lipomas which we operated in adulthood. So, as you have rightly pointed out, the most important thing is the pain. The indications are that these people came to the doctor at that age is because of the low back pain. They were investigated for pain by outside and then they came. So I do think that pain relief is a goal for surgery for adult lipomas, along with detethering as soon as possible. And the urological part is skepticality. Whatever you have to live, it may improve by 10-20%. And sorry.
I'm sorry, I was listening, Dr. Kushik, and I want to comment, like, I think my dilemma with the adult patients is the back pain and how to differentiate that from an actual lipoma or a natural course or a degenerative problem. When we are asked to come and assist with their adult lipoma with pediatric pathologies or adult cases with pediatric pathologies being phylum terminal, like little lipoma, fatty phylum, and small lipoma, I think I ask my adult colleagues to differentiate any back pain, which is what they brings them in mostly into their clinic from because of degenerative disease and other causes than a true lipoma and tethering. Because it is difficult for me to identify with their subjective symptoms, which one is which and how that's going to change their outcome.
Yep, that's it's a very good point. Very, very good point.
If you have any insights to how we can differentiate, I'd be happy to, like, abide by the rules, because you have more experience, Dr. Sill, about, like, adults and how to treat lipomas in adults.
It's hard, right? It's the same questions. I was circling back to the Q&A. There's a question here that I've heard asked many times in forums like this. If you have patients that have myelomeningocele and have hydrocephalus, moderate-sized hydrocephalus at birth, shunt at the same time or not? Simultaneous shunt or closure first and follow?
I have one perception. If the hydrocephalus is severe with a small cortical mantle and the child is just a newborn, less than 3 days of life, I prefer to operate together. VP shunt on the patient, close the myelomeningocele. If it's a mild hydrocephalus, we just repair the myelomeningocele and plan the VP shunt afterwards.
Yeah, I would agree entirely, Nelci. I must admit, I tend to have the permissive ventricular megaly type approach that I think Ab was referring to earlier. I think for the trainees and the students listening, perhaps the big thing is never, wherever possible, never to do the shunt before the myelomeningocele closure, because that seems to be associated with a much higher rate of shunt infection in that group.
Very good.
Again, if you have a huge meningomyelocele in which you have a premonition that it may give way, there may be CSF leak. We do occasionally put in shunts before.
Okay.
Very big, very cystic. Then we do put in.
So
Yeah, I guess in India you see a completely different spectrum. I mean, so you really go for the mega cases over there, I think.
So I think we've addressed most of the questions in the Q&A. If there are other questions on people's minds, please don't hesitate to type them into the Q&A. There are a couple comments about wishing to receive guidelines, and there's some emails there, so we'll attend to that and make sure. Nelci, any comments?
Now, Linda, tell us that these guidelines will be available, the link when this webinar is recording and put on the website, ISPN website will be there. Because on the chat, it's impossible to put the guideline on the Zoom like we would like to do it, she tell me.
I think we should put in another plug for the guide. Right, the ISPN guide is an available reference for all junior learners, for everybody, right? It's a growing and active and dynamic online free process for, free project that everyone can resource. It's basically intended as a online textbook, and it's available for you through the ISPN website.
And they are in actualization with the new PowerPoint for the ISPN speakers, and soon will be available online with, it's not a new edition, but with actualization for the same topics, with the new PowerPoint for the professors that allowed us to put the point there. And if no more questions, I'd like to thank you very much for being with us. The first webinar, it was on skull anomalies. The second webinar was brain anomalies. And today, Spina Bifida. And next webinar will be on September 24 on brain tumors. Hope everyone can be with us. And if you can give us the final words before closing this section, the floor is yours, please. Eileen?
Thank you so much for having me in this talk. I appreciate the opportunity, but certainly I think, as Jeff has mentioned, and you guys are always mentioned, is prevention, prevention, prevention is the first thing that we go. And unfortunately, we cannot provide every resource in every setting as we enjoy here in some higher middle income or developed countries. But there are ways, and I think it falls mostly on the neurosurgeons to lead the multidisciplinary teams at times, and we will trust our next generation that they'll take over and do it. Spina bifida is a very wide topic. It's difficult to tackle in a few hours, but thank you for having me and listening.
Thank you, Eileen. Nabila?
Oh, thank you for having me, and thank you for this great opportunity. Thank you.
Thank you. I was welcome.
Nelci, who'd you call on?
Hello.
Kaushik, yes?
Oh, Kaushik. Final thoughts, Kaushik?
Thank
Final
you
word?
so much. This is a wonderful event and what a wonderful organization participation. And the take-home message, as pointed out, is the prevention. So we must harpin and join the ISPN effort to spread the folic acid fortification program in the other countries also.
Thank you very much, Kaushik. Dominic?
Yeah, well, thanks very much, India. I think it's been really nice, actually, some lovely interactions, and I hope the juniors listening have got something out of it. And I think two messages I would give them from this. First of all, do no harm, go back to Hippocratic methods. And the second thing is, feel free to question dogma. Don't always believe what, today's truth is tomorrow's lies. Yeah, it's important that we're looking forward to change, not accepting what we do all the time.
Thank you very much, Dominic. Noor Maria?
So much, madam. It was a matter of real honor and pleasure to be a part of this very amazing webinar. And I really want to thank every speaker. And of course, I really want to thank Professor Nelci, who made it possible for us to conduct this amazing course. So it is a matter of huge honor for me to be a part of this. And I do think that this is a huge opportunity for every, at every level, from the level of medical students to the level of neurosurgical trainees and junior neurosurgeons, and it also include me, to be a part, to attend this amazing course and to learn all the important aspects, the important clinical aspects that will be very helpful in the clinical practice through this course, which is totally free and which always have amazing speakers like all of you here. So it is a huge opportunity, and I take a lot of pleasure and honor to have a part in this amazing course. I really want to thank all the speakers and for all the time that they have spared, especially for the discussion and for the Q&As. The lectures were really elaborate. I don't think there is any thing important that has been left. This is so amazing since almost every query has been already addressed in the lectures, and the rest of the things that were important were very nicely discussed during the discussion and the Q&A session. So again, I really want to thank you, and I really want to thank all the speakers and Professor Nelci.
Thank you, Nora Maria. We have some minutes more for MCQ, so we have more than 40 answers. Thank you very much for the attendees that answers the MCQs. Linda will stay a little bit more if you would like to send these answers and have the certificate for today. And Jeff, please.
Thank you, Nelci. Two comments. One, for the learners and junior doctors, you've heard that there is a lot of practice preference, and there's a lot of areas that we may not understand everything. You've heard very honest talks from people in the field leading the thinking about this that aren't definitive, right? We don't know many things, but it's a little bit like the weather. The weatherman, weather lady may not be able to predict with absolute certainty what's going to happen, but the basic principles are sound, are solid, and reflect a lot of thought and time over experience, or pardon me, over time. Don't take away from this that we don't know anything and everything goes and you can do anything. If a child with spina bifida is having trouble, think hydrocephalus, intervene, deal with the hydrocephalus, explore the shunt, treat the hydrocephalus. There are things we don't know, but there are principles, and some of them have been reviewed here. Treating the hydrocephalus is central to the well-being of children with spina bifida. You will serve them well by being very proactive in assessing and managing their hydrocephalus. You know it well, so do their parents over time. You and their parents form a link where you understand what's going on with that particular child. Second point, you heard Dominic Thompson say it. You will be the generation, someone somewhere out there among you will be the individual that begins to have the idea or the insight about the ways we can move this forward. How can we classify these lipomas better to sort out those which are going to show a poor natural history from those that are not? We're working as we can, but this one's probably going to fall on you. So it's not too early to start thinking about these things. Challenge dogma, as Dominic said earlier, and keep thinking. This is a very interesting, very challenging area, and I would just leave you with that challenge and our appreciation for so many participants in this program today.
Thank you very much for the speakers, for the audience. Thanks, Rick, the ISPN president, and Linda. Thank you very much for your kind support and help for this webinar being well like we are now. Thanks a lot for everyone.
Thanks, everyone.
And see you on September 24.
Have a nice weekend, everyone. Take care.
Bye-bye.